So hello, everybody. On behalf of the Muslim Medical Association of Canada, I'd like to welcome everyone to the COVID-19 ICU Refresher. Just keep in mind this will take place for the first hour and a half or so, and then later on we will be hosting an ICU and internal medicine question and answer period. So my name is Bilal Lone, and I'm a sports and exercise medicine physician in Hamilton, Ontario, and a board member for the MMAC. Thank you for joining us today, and I'm just going to get a quick shout out to the team that's come together to put these sessions together. So please note that this is the third in our webinar series. So last week we had an emergency medicine refresher, and then the week prior to that we had an internal medicine refresher. So these are great resources for people who, or more so residents who are looking at possibly being redeployed to services that aren't their home programs. So without further ado, I'm just going to give a quick shout out to our team and then we'll hand it over. So Dr. Arfeen Malik, she's a PGY5 psychiatry at U of T. Dr. Tanzila Basreen is a family medicine physician in North York and an ER physician in Lindsay, Ontario. Dr. Say Schwetz, she's a PGY4 emergency medicine physician at University of Saskatchewan. Dr. Nazia Sharfuddin, she's PGY4 internal medicine at University of Alberta. Dr. Hamza Qureshi, PGY4 internal medicine at U of T. Dr. Ahmed Faris, PGY3 public health and preventative medicine at University of Montreal. And then we also have Dr. John Lam, infectious disease specialist at University of Calgary. Dr. Nadine Qureshi, PGY4 infectious disease at Western University. Dr. Gemma Cox, PGY2 family medicine at U of T. And then Dr. Peter Cox, who is joining us today. I'm just going to do a quick intro to Dr. Peter Cox, and then we will get started. So Dr. Peter Cox completed his training in pediatrics and anesthesia prior to certifying in critical care. He was an associate chief and clinical director of the ICU at SickKids for many years. He remains a professor of anesthesia at the University of Toronto and critical care examiner for the Royal College. He retired from SickKids in 2018. He then decided to ride a bicycle from Cairo to Cape Town in support of the charity Changing Faces. Since then, he has enjoyed working in both a clinical and leadership capacity for Médecins Sans Frontières in low resource settings all over the world. So we're very honored to have Dr. Peter Cox and Dr. Gemma Cox presenting for us today. So I'll hand it over to them. And then if you guys have any questions, please type them in the chat. I'll keep track of the questions and we will save them for the Q&A at the end. Or if there's something that's pertinent or related to one of the slides, I will just interrupt the speaker. Thank you.
Thanks very much, Bilal. So I'm Peter Cox, and as you heard, I've retired from critical care, and I'm not actually actively involved in the treatment of COVID patients, but I certainly have been alerted to it, and I'm following it with great interest as we go through these troubled times. I think what's important is that what we're going to try and do is, if I can get my screen to advance, there you go, is that Gemma, who happens to be my daughter, and myself have discussed what we thought would be of value for people who are going to be working a little bit out of their comfort zone, and that's a lot of us at the moment, dealing with equipment they're not familiar with, teams they're not familiar with, drugs they're not familiar with, and probably most importantly, patients carry enormous risk, not only to the patients, but also to the caregivers. So take care, everybody. What we're going to try and do is give you a background so that you get a better handle on understanding when these patients get sick enough to require admission to an ICU or to a high intensity ward and need some respiratory support, what that actually means, both physiologically, and then we'll talk a little bit about the mechanical ventilator and also what happens when these things don't help you get better. So I have no conflicts of interest to declare other than I still like riding a bicycle and keeping fit, and I hope the rest of you do the same thing. And as far as I know, the only conflict that I have is I'm doing this with my daughter. So there's a little bit of a family conflict there. So without further ado, let's dive right into it. Our objective is to give you a bit of background in respiratory physiology, high-risk airway management, and then the basics of mechanical ventilation, remembering that the sickest of these patients who get admitted to the ICUs do require mechanical ventilation. That's about 5% of them. And mechanical ventilation is very scary when you look at these highly technical, complex machines, but in fact, I'm going to break it down so it's a lot more simple than you think. I'm going to leave Gemma to do the coronavirus clinical review, and I'll speak a little bit about ARDS, and then we'll get into some of the resources, palliative management of respiratory failure. I've tried to aim the talk at a number of different levels, recognizing that some of my former trainees are on the line, as well as physicians who work in emergency rooms and general medicine, and all of you may be deployed to look after really sick patients. So where are we? This is terrifying. If you look at the map in the top right-hand corner, I can't see many parts of the whole world other than probably the Antarctica that are not affected. And it just seems to be growing every day. This is data from 1454 Greenwich Mean Time today. 1.25 million cases with 66,000 deaths, and it's growing all the time. Somebody referred to this as our Pearl Harbor, one of the American politicians earlier on today. So let's get right into it. What is critical care? Essentially what I've spent the last 3 decades of my life doing is supporting patients in an environment until such time as either their bodies heal themselves or the medications and therapies that we use help them to do so. Critical care environment is actually a sort of physio-pharmacological, pathological environment where we deal with patients whose organs have failed or are failing and require some form of support. And we're going to focus today particularly on respiratory physiology. And fundamental to a lot of what happens in the lung and the rest of the body is about a pressure gradient. And to remind you, fluids, we're talking about gases in the first instance, and then about dissolved gases in the second instance, move down a pressure gradient from a high pressure to a low pressure, much the same as the wind does. And if you think about our lungs, what essentially we're dealing with is an airway tubing, which is the trachea, which breaks down into primary and secondary bronchi, and a pump pumps gas down these tubes into the alveoli, and it's in these alveoli that gas exchange takes place. Ideally, what one wants to do is to make sure that every molecule of gas that you want exchanged is interfacing with blood so that you've got optimal gas exchange. And I'm going to use my pointer. What you can see in the middle is a VQ, which is ventilation over perfusion, which is essentially 1-to-1. In other words, every breath that I'm taking in is well matched with blood flowing past the lung. On the right-hand side of your screen, you can see that this alveolus, this testicle or ball, is ventilated, but it's not being perfused. And this is called dead space, and it becomes important later on, we'll talk about it. On the right-hand side, you can see this alveolus is blocked at this point, so it's not being ventilated, but it is being well perfused. And this is key to the understanding of a lot of what happens in the lung. Now, as I'm sitting here breathing, my own respiratory muscles are acting as a pump. I'm inspiring with my external intercostals, and if I actively exhale, I'm using my internal intercostals. I also have a diaphragm, and I've got sternocleidomastoids and many other muscles that contribute to pumping gas, in this case, sucking gas into my lung, because the difference between when we're breathing spontaneously, in other words, we're creating a negative pressure in the alveolus, when somebody goes onto a ventilator, we're actually pumping pressure under positive pressure into the lung itself. And this clearly is not the physiological way to ventilate and has side effects which can be quite significant. What we're trying to do when we're doing this is I've used a molecule of oxygen from ambient air, which is an FiO2 of 0.21. It goes into the alveolus and then flows from the alveolus, diffuses into the circulation, and finally goes down to the mitochondria down here. And what's important, on the right-hand column, you can see this is oxygen tension, and you can see that in the mitochondria itself, the oxygen tension is actually quite low. But what happens in this part, ventilation and circulation, is absolutely key to ensuring that our bodies continue to function the way that we want them to. Just to understand some terms, those of us who work in an ICU environment use these terms all the time, and we forget that not everybody's familiar with them. FiO2 is the fractional concentration of inspired oxygen, and commonly we use a percentage, but the actual correct way to use it is as a fraction. So someone who's on 60% oxygen, and this becomes important later on when we're talking about calculating how sick somebody is actually on 0.6 FiO2. The P big A O2, this is the second point down here, is actually the concentration of oxygen inside the alveolus. And this is important when we talk about diffusion, and I'll come to that in the next couple of slides. P little AO2 is the dissolved oxygen in the blood. Here you can see venous blood going past an alveolus, picking up oxygen, and oxygen is dissolved as PaO2. Commonly, what we measure in an ICU on one of the wards is the saturation of oxygen. And what you see is the number up on the screen is the saturation up to 100%. And that is actually the amount of oxygen that's carried on hemoglobin. In many ways, that is really what's most important. I put up this equation of oxygen delivery. And in the middle, you can see saturation of oxygen and hemoglobin multiplied by 1.39. And that fraction, even if this is 100, the PaO2 is 100, you can see that you're multiplying it by 0.003. So the amount of oxygen in the blood is actually better reflected by saturation of oxygen. Now, this is also particularly important in a time where not everybody has invasive monitoring, so you can't always get a PaO2, but you can very quickly assess a patient's oxygenation by looking at their oxygen saturation. That's why I haven't put that up there. So let's see how oxygen gets from the air that we breathe in into the blood. And essentially, you've got an alveolus on the left-hand side of your screen. Oxygen goes from the air into the alveolus and goes across this membrane into the blood, while CO2 comes out. And the amount of oxygen entering into the blood from the alveoli depends on the pressure gradient. Here's P1, and there's P2. This is in the alveolus, and this is in the blood. So the pressure gradient across this membrane is one of the driving forces to diffuse oxygen into the blood. This is P1 minus P2, that pressure gradient over there. The other very important factor is the surface area. Oops. Because clearly, the larger the surface area, and our lungs typically have about the surface area the size of a football field, the alveolar surface, to allow oxygen to diffuse from the alveolus into the blood. So surface area is particularly important. I've also got thickness on this slide. There's thickness, and this is the alveolar capillary membrane. And I'm not going to focus on that because the things that we can actually adjust are the partial pressure gradient and the surface area. And that's where a lot of this talk is actually focused on. Just to say in words what that picture actually depicted is the movement of oxygen into the blood from the alveolus is oxygenation, and the amount of oxygen is dependent on surface area and the pressure gradient across them. Here's another picture to make you see that. Oxygen, alveolar capillary membrane, pressure gradient, and then the surface areas on this side. So you've got alveolar oxygen on the one side, that's your P1. Venous oxygen, saturation on the other side is your P2, and the gradient between these two allows oxygen to flow down from high to low. Because people are not familiar with alveolar oxygen so much, the surrogate that I use is FiO2, and there's a calculation that I can calculate PaO2 from FiO2, but I'm not going to get into that in this slide. Surface area, easy to see. Two balloons, one is partially collapsed, the other one's fully inflated, and it's easy to see that with a well-inflated balloon, your surface area is much, much more than it is in this partially deflated balloon. And if you think about a lung that is either compressed or got fluid in it, the surface area is significantly diminished. And things that we can do in an ICU on the wards for these patients is to provide factors that will mitigate the loss of surface area, and we'll get into that later. To reiterate, venous blood comes in with a PaO2 of about 40. That's a saturation of about 75, a PA or PV CO2 of about 45, and it flows past the alveolus. Your oxygen within the alveolus is about 100. That goes into the blood, which then comes out with a saturation of somewhere from 95 to 100 with a PO2 of about 100. So that's what happens in the alveolus. Pretty simple, and our job is to try and make sure that we make it get oxygen across this membrane as effectively and efficiently as possible. What about CO2? if you think about what our lungs do, in the one direction, oxygen goes in, and in the other direction, CO2 comes out. Now, what governs CO2 is the amount of ventilation that you do in 1 minute. You're all familiar, I'm sure, with hyperventilating, getting tingling in your fingers, and that's because you've blown off a lot of CO2, and that has an impact on your pH. But essentially, by hyperventilating, in other words, increasing your minute ventilation, you have blown off CO2. Similarly, if you see a patient who is given a muscle relaxant or is given too much narcotic and they don't breathe sufficiently, their minute ventilation is decreased and their CO2 is going to increase. So PaCO2 is inversely proportional to minute ventilation, which is made up of tidal volume, i.e. one normal breath, and the number of those breaths in a minute, VTF. Yeah, we have another look at this. This is what I've just said. Less ventilation leads to a higher CO2, and this can either be smaller tidal volumes or lower frequencies and rates. That's your minute ventilation. More ventilation, hyperventilation, increased tidal volume, increased frequency will decrease your CO2. Simple concepts, but remember that you can apply them.
Sorry, Dr. Cox.
Yes.
Just to interrupt. There's a question here that assuming no anemia, which one drops first, the PaO2 or the SpO2?
Well, depending on how low your blood hemoglobin is, your SaO2, your saturation, will actually stay up for quite a long time because it's the amount of oxygen saturation per se. The PaO2 will remain pretty much the same because it's dissolved oxygen within the blood. Okay?
Yes, thank you.
All right. Right. When we're talking about minute ventilation and tidal volume, every breath that we take, not all of it actually goes to active gas exchange. And this little diagram I've got in the bottom right of this slide shows that if I take in a tidal volume breath, VT, that's made up of alveolar ventilation, this little alveolus over here, and dead space ventilation. Now, dead space ventilation does not participate in gas exchange. Probably the best example of that is somebody who has a massive pulmonary embolus and blocks off their left pulmonary artery. So I can still be ventilating this lung, but not perfusing it. So that becomes physiological dead space. And clearly the bronchi and trachea have no gas exchanging membrane. So they do not participate in active gas exchange. What's important is alveolar ventilation. That becomes the gas exchanging volume that's important. If you flip this around and look at what we can do in a high intensity environment where we're monitoring patients who are on either mechanical ventilation or breathing spontaneously, although it's much easier to do it with mechanical ventilation when a patient is intubated, is we measure end-tidal CO2. And what end-tidal CO2 is, it's the end of your breath, in other words, the last few milliliters of breath coming out of your lungs when you breathe out, which comes from your alveoli that are being perfused. And therefore, it's a good reflection of your arterial carbon dioxide concentration. So in an ICU environment, or when you're intubating somebody in an operating room, we'll use end-tidal CO2 as a reflection of alveolar ventilation, in other words, VA, that has got CO2 that's come out of the bloodstream into the alveolus. So that's what end-tidal CO2 is, and it's a very good surrogate for PaCO2 down on the bottom of the slide. Again, the same slide I showed you earlier, and what you want is a good matching of perfusion and ventilation, and if you have that, end-tidal CO2 will reflect the CO2 in this alveolus and all the other alveoli that are well perfused and well ventilated. If it's end-tidal, it will show you the CO2 at the end of a normal respiratory breath. So if you think of the causes of a high CO2, either you've got increased production, so your body's hypermetabolic, because remember, CO2 is a byproduct of metabolism, or you've got decreased excretion, and we've already spoken about that, when either your tidal volume or your frequency or both are decreased, and you've got decreased minute ventilation. Fundamentally, what I've done is discussed oxygenation, the movement of oxygen into your bloodstream, and carbon dioxide removal is the flow of carbon dioxide, which flows very easily across the membrane and is less surface area dependent. It is more ventilation dependent. And those are the two gases that we most focus on when we ventilate a patient in the ICU. The two other quick concepts that I want you to understand, the one is lung volumes and the other one is compliance. And when you think in lung volumes, go back to when you were at medical school or doing respiratory physiology. At some point, on the left-hand side, I've got volume. On the right, on the horizontal axis, I've got time. And this is somebody taking a normal breath in and out, and in and out. So those are normal tidal volume breaths. If I take a really big breath in to the maximum that I can, it's called inspiratory reserve volume. And then I breathe out to the maximum that I can, it's called expiratory reserve volume. Why I really want to show you this particular picture is this concept of functional residual capacity. Because what functional residual capacity is the volume in our lung at the end of a normal tidal volume breath, and it reflects the reservoir that we have for gas exchange at the when we're not actively breathing. So that will become important when we speak about intubation and pre-oxygenation later on in this talk. What I've just mentioned are the tidal volumes. It's the amount of air moving into and out of the lung with each breath. And the FRC, you can see down here, is what's left in your lungs at the end of a normal tidal volume breath. Fairly simple concepts, but you're going to dial in either a pressure or a volume on a ventilator, and that's going to be the equivalent of your tidal volume. And remember that at the end of that breath, what's going to be left in the lung is your functional residual capacity. What about compliance? This may be stretching your memories a bit, but compliance is really the stiffness of the lung. One of the ways of understanding this is take a new balloon, put it up to your lips, try and blow it up, and you can feel that it can be initially quite stiff and then it'll open up. So if you get a balloon that's got a very thick kind of rubber, you'll have a very low compliance. In other words, you need a very high pressure to get a low volume in. And if you've got a balloon that's made of very thin latex, you can get, with a little pressure, you can get a large volume in. And I'll further explore those concepts when we speak about the kind of ventilator settings that you might see in the ICU. These are just an example, 20/10. And then what I've done here is I've taken lungs with 3 different kinds of compliances. Clearly, this one in red line, the lung needs a pressure to get a relatively low volume in, so that is poor compliance. And the green line, at the same pressure, I'm getting 3 times the volume in. So that's good compliance. Ideally, you want to be in this part of the curve, not this part of the curve. And when you're sick, this line gets pushed further and further downwards. So when you think about compliance, just think of stiffness of the lung, think about a balloon, and then think about how tough it is to blow up a balloon. And that's similar to what a ventilator has to do when you're in an ICU. So if you put it all together, increase oxygen in the blood, you optimize the surface area, and you increase the partial pressure gradient across the alveolar capillary membrane. To remove CO2, you optimize the effective alveolar ventilation, VA, and ensure that you do enough of that in every minute, and you will get your blood gases back towards normal. I'm going to have a break at this point before we go into the next part of this talk, and that is just to allow for any questions. And so I'll hand it over to Bilal, who can throw any questions our way that have come up on the chat.
I'll let you know as they come up on the chat. Nobody has anything yet, so we'll just give people a few moments.
And while people are thinking of questions, please don't hesitate to send them through to Bilal. I may be touching on areas that you're not familiar with, and I hope that I'm explaining it in a way that allows you to grasp the fundamental concepts of why we do what we do.
You must be doing a great job because I got no questions here yet, so I'll let you continue.
Or I've confused everybody, that's the other thing.
Wait, I spoke too soon. Give me 1 second.
I saw it pop up.
So
Yeah.
it says, in concerns with ARDS, compliance decreases, increasing the pressure needed to achieve volume is the question.
Yes.
Confirming that.
Was there any more to that question?
No, that was the end of it. So it said, in concerns to ARDS, compliance decreases, thus increasing the pressure needed to achieve the volume.
That's an excellent question. And as we move through this talk, I've actually got a slide that illustrates that really nicely for you. So I'm going to put that on hold for a little bit, if you don't mind. Next question.
Next question. What is the threshold for ECMO, and who are the patients who will be triaged to ECMO?
I think what I've done so far is really speak about respiratory physiology. I'm going to get into the management of ARDS per se, and then we can talk about the role or not for extracorporeal support. I think at this point in time, we haven't even got our patient intubated yet, and so let's put that on hold until we are ready to address it.
So somebody's question here is, to clarify, what are the physiological issues in COVID specifically, i.e. is it an issue of diffusion, perfusion, etc.? I'm not sure if you're going to get into that later on, or I think what we'll try to do, everybody, for the questions is try to keep them to the respiratory physiology we've done so far, and then the more COVID specific and more advanced things regarding ARDS and whatnot, we'll get into as the slides go on. I don't know if Dr. Cox, if you want to answer that one.
No, I think that's appropriate. I'm treating this more as an ARDS, because if you look at the spectrum of ARDS, ARDS is more like a syndrome. And within that syndrome, it's really about oxygenation and CO2 removal and the diffuseness of the injury. I will talk about COVID in a moment, although I don't have, in my reading, I don't have sufficient knowledge about what differentiates COVID per se from, for instance, some of the other viral pneumonias that we see, like influenza.
Okay, perfect. I think you're good to continue.
I think at this point, Gemma's going to take over. Gemma?
Hey,
we should be able to hear you now, Gemma. Sorry.
Okay, perfect. So I'm just getting my screen organized to make sure it's in the sharing mode. If I can get someone to give me a thumbs up once that takes effect, just so that I know that everybody can see the same thing. Okay, or actually, yeah, Bilal, can people see my screen?
No, not yet.
All right, give me a sec. Say share.
Yep, now we're going to your screen. We're good.
Excellent. Okay. All right. So yeah, as Pete was saying, that was really just a brief reminder for those of you who haven't practiced respiratory physiology in a while. We thought it'd be easier to simplify things, give that up front, and then later on, we're going to be progressing through how COVID specifically presents and physiologically what the impacts of that are. As this is a talk that initially in formulation was geared towards residents facing redeployment, I thought it would be helpful to do a quick review of ICU functioning in general as a junior member of the team or someone who's not the MRP in terms of daily assessment. And the way that I'm introducing it is through a series of evidence-based practices. You can remember them with the mnemonic FAST, HUG, BID. So you need to go through these things at least once daily, typically 2 or 3 times a day, because there's a lot of rounding in ICU. So feeding, you want to make sure if the patient's NPO, have you assessed how long, when are you going to consider transitioning to TPN? And if they're not NPO, confirm that they do have a diet. If they don't need to be NPO, restart their feeding. In terms of their analgesia, you want to be monitoring for signs of discomfort, patient pain, if the self-report is not available. You can look at other parameters, heart rate, resp rate, grimacing, but ideally it's self-report. Sedation, we're trying to minimize it where possible and avoid benzodiazepines, again, if possible. The rest of DVT prophylaxis is always something to think about. Head of the bed elevated at least 30 degrees to facilitate ventilation. And the rest of them you can kind of read through yourself, but it is a series of functions that should be reviewed sort of for anyone who's participating in the ICU team. In terms of mechanically ventilated patients, just a nice graphic. So reminder to always make sure that you're engaging the family, trying to get them, especially in today's current climate, it's tough to get everyone on the same page, but as much as possible to try and involve them in the patient's care, to mobilize the patient whenever they are able to avoid physical restraints if possible, and to try and detect agitation and delirium quite early. Next, I was going to just go through sort of the spectrum of oxygen delivery and what we're able to do. So the basic form, the most basic form that we can talk about pertains to nasal cannula. This can give you an FiO2 of up to about 40%, although some will debate that. And you can support a flow rate, meaning how much volume of air you're providing to the patient per minute, of about 1 to 6 liters per minute. If you go up a level, you're looking at the face mask. The face mask can support 6 to 10 liters theoretically, and theoretically an FiO2 of 40 to 80%. One level up is your non-rebreather. Typically that can go 10 to 15 as a max, and again, theoretically can reach an FiO2 of 100, but in real life it's more like 70, 75. All of these things can be provided on the ward, not in an ICU. When you call outreach or you're starting to think about transition to an intensive care unit, if the patient can't ventilate or oxygenate themselves, you're going to be using a bag mask and a handheld ventilation protocol. This is under a lot of question in the time of COVID because it is considered an aerosol generating procedure, as is everything to the right of the bag mask. So high flow nasal cannula, CPAP, BiPAP, and mechanical ventilation. And the latter three there are provided in an ICU. High flow nasal cannula supports flows of up to 60 liters per minute. But again, most of these are being nixed in the era of COVID, so check with your hospitals to make sure what the protocol is. This is just a memory aid for those of you who might want to refer back. It's to show you the flows and FiO2s that can be supported by each of the parameters. In terms of intubation and airway management, intubation is always a high-risk procedure, and in an emergency setting, forget COVID, in an emergency setting, it's always very high risk, not only because of anatomy, but also because of the patient's pathophysiology at the time. So these are some numbers that have been quoted from the American Journal of Respiratory Critical Care. They produced a 2013 article, and it showed that 30% actually suffer severe cardiovascular collapse after an emergency intubation. So the following slides are really to provide some context, but especially now when the stakes are so high, the most experienced airway personnel should be the one providing intubation. In terms of anatomical features that can complicate airway management, these pictures on the right give you a good example. Small mouth, if you can't open your mouth, if your dentition is abnormal and obstructing your view, if you have a very small chin, such as this one here, you might be able to see the cords when you place your scope in, but you won't necessarily be able to curve the tube up to access them. And then obesity, in terms of accessing the airway, can be quite challenging. And then there's three main physiological predictors of cardiovascular collapse post-intubation. We're only going to go through the first two because those are the ones that are quite relevant at this time. So in terms of hypoxemia, these patients, if they are hypoxic prior to intubation, their SATs will just sink immediately upon placing that tube. Anything can contribute to that, so anemia, low cardiac output, VQ mismatch, and a hypermetabolic state. For all of those reasons, you have to be really careful with these patients. And a SAT of less than 70% is going to increase your risk. That's a pre-intubation SAT of less than 70% is going to increase your risk of dysrhythmia, cardiovascular collapse, MI, death, hypoxic brain injury, all that bad stuff. So as my dad was hinting at, pre-oxygenation, which is when you fill your functional residual capacity up with pure oxygen, it's critically important, and it extends the amount of time available for the provider to access that airway before SATs start to drop. So it's quite challenging in the era of COVID because we don't have the ability to bag the patient, obtain that good seal and bag them on a true FiO2 of 100%. So what some of the protocols are suggesting is a non-rebreather mask. So that's the highest level of oxygen provision without generating an aerosol. Using a non-rebreather to deliver a max of about 80% at 15 liters, and you do that for about 3 minutes. And then other ways that you can optimize pre-oxygenation is ensuring that the patient has their back up and head elevated, and a ramp in particular if they are of obese body habitus. For hemodynamically unstable patients, they have decreased preload upon intubation due to positive pressure. You're also using drugs, or if you are using drugs, that can impact your myocardial functioning as well as cause peripheral vasodilation. And then you have whatever your underlying pathology is that's causing the patient to require this procedure in the first place. So the goal is to always resuscitate before you intubate. Ideally, you want to make sure that you have 2 good running sort of large bore peripheral IVs and volume load prior to intubation. Although again, check with whichever institution you're at because the protocols vary from hospital to hospital. Some do consider also starting pressors if after your first 1 or 2 fluid boluses, the MAP remains quite low. That's a point in time at which some would consider starting pressors. You want to try and use hemodynamically stable induction agents. And typically for an unstable patient, you're reducing your induction agent dose to about 50% for patients with uncompensated shock. So patients that you've been unable to resuscitate and who remain hemodynamically unstable, you want to make sure you're using a very low dose of the induction agent. We haven't specified specific drugs for this presentation because I think that it's highly dependent on what you have available and what you're comfortable with. But these are just some general principles that you can consider in terms of choosing your doses. So when it comes to intubating with COVID, it's high risk. The patients are likely hypoxemic. They're hemodynamically compromised. Your options are limited, and you've also got some risk to the healthcare personnel. So again, it should be managed by the most experienced clinicians. Ideally, it's anesthesia, your ED staff, or your intensivist. In terms of indications for intubation, these are just the general indications for placing an airway. So it's someone who can't maintain or protect their airway, someone who can't ventilate, they can't breathe in and out, so their CO2 is rising, and they can't oxygenate, so their SAT is dropping. And then the last one is really something that comes with experience. It's where you start to anticipate the deteriorating course. So if you expect that a patient is going to get much worse, you would intubate them before that occurs to keep them as controlled as possible. When you're considering an intubation, you want to think about these 3 things: airway, breathing, and course. In terms of your airway, this is just an example of a couple of different types of patients that may be fine in terms of their airway and then may actually require management. So if someone is able to phonate clearly and answer questions, you know that their airway is patent, that they're able to breathe, and that they are perfusing their brain. If they start to drop their level of consciousness less than 8, that's a reason to intubate someone because you lose your airway reflexes, so you actually can't prevent aspiration. And if you're judging whether someone can protect your airway, think about whether they're phonating and swallowing their secretions. The last one here, lack of obstruction. This is more general airway management, especially in trauma, but you do always want to consider whether there's laryngospasm, foreign body, or soft tissue. Just sort of a pearl, if you have a patient who's tolerating one of those C-shaped oral airways, it typically indicates that they are obtunded enough to require intubation or some form of airway management. In terms of breathing and an inability to maintain your SAT above 92. And in terms of ventilation, it can be either a lower or an upper respiratory tract infection, or it can be any of the things that are listed here. Oh, actually, we'll just go back for a sec. For the more junior learners who are present, when you're assessing ventilation, always take a look at the respiratory rate, how awake someone is, how deep they're able to inspire. Are they breathing very shallow and fast, or are they taking deep functional breaths, and whether there's any signs of increased work of breathing. This last one, clinical course. If you have someone with deteriorating respiratory distress, so prolonged hypoxemia that you can't correct with some of those early non-invasive methods discussed earlier, as well as anticipating the need for fluid loading, needing an emergent procedure, anyone with hemodynamic instability might require intubation, and then prior to transport. So in ICU patients, some of the things that we think about, this top one, the PaO2 to FiO2 ratio, your P to F ratio, Anyone under 300 to 200 is typically considered for intubation. This is really a term that came about in discussions regarding ARDS, and Pete is going to speak to this in a little bit. But some of the other parameters include a very high resp rate, a low PaO2 despite an FiO2 of 50%, and a climbing PaCO2. Again, for the more junior learners, as soon as intubation is complete, you typically auscultate. Not necessarily in the era of COVID, we use other parameters, or we rely more heavily on those other parameters to confirm ET placement. If you are auscultating and you do get unilateral breath sounds, you want to consider a right main stem intubation, so the ET tube has entered it's gone too deep and it's entered one of the main stem bronchi. So you'd confirm end-tidal CO2. We would typically do a chest x-ray to check for the position. And most ICUs, you'll order an ABG in about 20 minutes, as long as your SAT is above 93 to 95, to get a sense of where you're at from a ventilation standpoint. And then you'd also order whatever sedation is necessary.
Sorry, Gemma,
in terms of mechanical ventilation, I'm going to pass this back over to my dad, and he's going to take it from here. So... Okay, so take over.
I just had to unmute him, sorry.
No problem.
Before you guys move on to the next slide, I just have somebody here asking if you have a patient on the ward or hospitalist maintaining their SpO2 around 90% despite O2 supplementation, sorry, where to go? Who should we, as non-ICU providers, think might warrant an ICU consult / preemptive intubation for risk of decompensation rather than waiting for them to code blue?
Right. So sorry, just to clarify there, the question is when to consider ICU consult?
Correct. And when to consider preemptive intubation for thinking they're going to decompensate. So basically, if you think somebody's going to decompensate, when should you consider ICU consult or intubating them beforehand? Sorry, Gemma, you're muted. One sec.
Earlier. Cannot maintain.
Sorry, you were muted earlier. So.
Oh, no problem.
Go ahead.
So in general, we are going to speak more closely to this later on, but in general, it's patients who you cannot or who are unable to maintain a SAT an FiO2 of 50%. Guidelines vary very much dependent on which institution you're looking at, which source. But the one that I've most commonly seen quoted is 92 to 96. Some might say 88 to 95 on at least a minimum, or sorry, a maximum FiO2 of 50%. And then I think there are a few other questions there.
Sorry, your volume's very low, or your mic is very low for some reason. We could barely hear the last part of that answer. And now you're muted again somehow. Why do you keep getting muted? There, now you're unmuted.
All right, can everyone hear me?
Yes.
Okay. So just in terms of who to refer to ICU early, I'd say it's anyone, or not me, the guidelines say that anyone who can't maintain their SAT, either 88 to 95 or 92 to 96, depending on your target, at an FiO2 of 50%. I'm just looking through the list. There's a couple other questions. One from Norin about avoiding benzodiazepines. I agree in what my limited residency exposure has provided so far. Most ICU patients are on benzos. I think the point from that guideline where the slide was made was to say, if possible, try and focus on alternatives. And that was just based on a study that looked at ICU delirium and agitation. But you're going to have to clarify with whoever the treating physician is and whatever the norm is in your team.
So there's a question here about not auscultating somebody with COVID. So it's saying, do you not auscultate somebody with COVID after intubation, or do you not auscultate them at all? And then somebody earlier had a similar question and said, is it to avoid patient-to-patient transmission or patient-to-provider transmission?
Yep. So for the auscultation piece, again, it does vary somewhat on the guidelines. And just for the future, the guidelines that I'm quoting and the guidelines that have been used to create these slides, these are the University of Toronto Interdepartmental Critical Care Guidelines, and they're freely available. I'm not involved in making them. they're available for all of the U of T staff and residents to access. So in terms of auscultation, the suggestion is to avoid auscultation in a non-ventilated, non-intubated patient, period, to rely on your passive or your observation of the patient's work of breathing, their vitals, and whatever imaging you have. In a patient who is bound for intubation, the guideline suggests avoiding auscultation to confirm ET placement if you were able to see the tube pass through the cords, if you have confirmation of end tidal CO2, and if you have, for example, a chest x-ray that shows the placement of the endotracheal tube. The only time that this guideline suggested auscultating a patient is if there is a sudden change in their respiratory status. So if the intubated ventilated patient suddenly deteriorates, they do recommend auscultating. And there should be a dedicated stethoscope for each patient with COVID who's intubated, and you would clean it both before and after auscultation. The risk of auscultation is that your stethoscope and whatever else touches the patient becomes a fomite for droplet transmission. So they're trying to minimize that as much as possible. It's an instrument that is very close to your face. It's touching the patient. If there are respiratory droplets and it becomes contaminated, you might self-contaminate. So that's the rationale behind it. Does that make sense?
Just waiting for the person to respond. And yes, it does.
Okay.
So, perfect.
Awesome.
I'm just going to take one more question and then I will leave the other ones. Just briefly, it says here, we usually use atropine in infants only. Should we use them for older kids as well?
I'm going to let my dad answer that one.
Chicken. So atropine, it's not routinely used anymore, and I think one can get into a long debate about it, but it's not part of your routine intubation drugs. Because really, when you were using drugs like succinylcholine, which has an effect on the vagus, can slow the heart rate down, so you want to prevent that, and that's why you use atropine. The other indication for atropine is for secretions. Again, I'm not sure in this particular environment where the atropine is indicated. I know that it's fallen out of favor in most anesthetic intubations. Okay, can we move along?
Yes, go ahead. I'm going to.
So the next phase we're going to talk about is mechanical ventilation. And if you look at what's up on the screen in front of you, the goals are pretty much going back to where we started off a while ago, is improving oxygenation, pressure gradient and surface area. You're going to be tired of hearing that by the time I'm finished. And improve minute ventilation is what controls your CO2. So you walk around a hospital and many people are terrified when they see a $65,000 machine that looks like this. It's got a screen with lots of numbers, lots of waveforms, and it's got people that look like they intensely know what they're doing. When I think of a mechanical ventilator, I think of something as similar to just fundamentally a pump. What I'm doing, think of a bicycle pump, and this is what you're going to pump in. As you push this in, you push the gas into the patient. The patient then exhales, and as this comes out, you fill up the cylinder with fresh gas, and when you push it in again, you push it back into the patient. So essentially, old-fashioned ventilators were just quite similar to a bicycle pump. And I know that in India, I had a colleague of mine just yesterday, they now have designed a very simple mechanical ventilator for $500. One of the car companies has done that. And essentially the principle that it's using is exactly what you can see on the screen in front of you. So what are the things that a mechanical ventilator actually controls? What are the knobs that we want to work with in that machine? The first, and probably one of the most important ones, is the amount of oxygen that I'm actually delivering to the patient, the FiO2. The second one is PEEP, positive end expiratory pressure. And what I'll do is I'll show you in a minute on the diagram what that actually looks like and what it means. But it has become an essential component and mainstay of ventilation in patients with ARDS and many other lung diseases. And we will talk about how it's used and manipulated when oxygenation becomes a problem. The other two knobs that you've got on the ventilator are for volume and for pressure. I put them in the same knob, and I'll show you in my very complex diagram coming up next. And that's going to be how we control the tidal volume that I'm pushing into the patient with each stroke of my pump. And then the last one is the rate or the frequency, F. And what that is how many times I'm pumping in every minute. And you know that as an adult, your normal respiratory rate is somewhere between 12 and 16. Whereas if you look at a newborn baby or someone who's in respiratory distress, that can go up as high as 60 or 70. So that's your frequency. So this is my very complex ventilator. Essentially a machine that I can control the amount of oxygen I'm giving to the patient, what pressure or volume I'm actually using, and I'm going to explain more of that in a little minute. The amount of positive end expiratory pressure, in fact, that's at the end of a breath, end expiratory. We want positive pressure, and I'll show you exactly why we need that. And then my frequency down here is how many breaths I'm going to deliver every minute. So you recall that I said the FiO2 is normally given as a fraction of 1. Remember that pure oxygen is toxic. So many people will say, well, if you've got somebody who's got oxygenation failure, why didn't you just leave them on 100% oxygen? Well, it's not good for your pulmonary cells. And so we try and get them down below 60 as soon as we can. Not always possible, but at least it is one of our goals. I'm going to sneeze, excuse me. I can't do it on screen, sorry. So I'm going to titrate oxygen, and I'm going to titrate it to my saturation, because what I want to do is I want to decrease from 100 as soon as I can, as long as my saturation, we're going to talk about saturation goals, but I want to maintain a saturation of about 90. And I'm using words like about and above because none of these are actually written in stone, none of them are concrete, and you have to be adaptable depending on the pathology that the patient you're looking after has within their lung. Clearly what you want to do is to aim for the lowest FiO2 possible. And again, to remind you, oxygen moves across the alveolar capillary membrane driven by your partial pressure gradient. So if I increase this by increasing FiO2, I will increase the gradient and drive more oxygen across into my blood. One of the things, somebody asked a question about pathology, and if you think about this is my alveolar capillary membrane, and clearly if I increase the thickness of this, if you can see my little cursor, if I double the thickness of this, this becomes an obstruction to moving oxygen across it. So that is one of the aspects of pathology that you do see in ARDS and in COVID in particular. I just looked it up. And so those are things that you want to actually work on. I mentioned PEEP, and I told you I was going to explain to you what it meant, what it looks like. But what it does is it provides a continuous baseline pressure in order to keep alveoli open at low lung volumes. And what this does is it maintains surface area. So what I've done, and this is lifted straight from the internet. I just found a picture of inflated and deflating balloons. And if you can imagine the lung, as I'm blowing it up with the tidal volume, the volume in the lung gets bigger and bigger and bigger. And clearly, this is where I want to maintain my lung volume to optimize ventilation. Ventilation, oxygenation, and oxygenation, as I've said to you a number of times, is dependent upon surface area, one of the factors. So if I think about this as inspiration, and at the end of inspiration, I'm going to breathe out in this direction, so I'm going to lose all that volume that I've so carefully gained. So what can I do about that? If I apply PEEP here, and I stop the lung from deflating to these two, by applying PEEP, my next breath will only work where I've drawn this circle. So now I've optimized lung volume, and by optimizing lung volume, I optimize surface area, and by doing that, I improve oxygenation. This is a very old diagram from, you can see the Handbook of Physiology, 1964, in the days when we still read books rather than screens. I love this picture though, because it illustrates very clearly, this is a rat lung, and on the top left-hand corner is the word inflation, and below that deflation. What you can see on this lung is that as I generate pressure and add volume, suddenly the lung expands from this fairly poorly inflated lung to a nicely inflated lung. And then at the end of inspiration, which is this picture over here, I'm going to allow the lung to deflate. And as it deflates, you can see that at, for example, a pressure of 8, my lung volume here on the deflation curve is much better than my lung volume here on the inflation curve. So if you think about this, this is what we'd call a pressure volume curve in respiratory physiology. And you can imagine on the top line, I'm inflating my lung along this line, and then I'm deflating my lung, and I'm going to stop there and add PEEP. So I'm not going to deflate down here. I'm just going to work in this part of the lung. So ideally, that's what we're going to try and do. Lung volumes. One of the other knobs on my machine was lung volumes and lung pressure, and mechanical ventilator pressure. Just to remind you, the tidal volume is the amount of air that you use with each single breath. It's not the sigh and it's not the big exhalation. It's just your regular tidal breathing, at the end of which you're left with, in your bottom right-hand corner, functional residual capacity, which continues to maintain gas exchange over time. All right? So now let's look at pressure and volume together. If you think of a bicycle pump again, I have to generate a pressure in order to drive the volume of gas into the lung. So you pump with the bicycle, pump, and with that, you drive a volume of pressure into the lung. And the ease with which you can do this is dependent on the stiffness of the lung. So if you've got a lung that is very floppy, has got no pathology, it's very easy to pump it up. If you've got a lung that's very stiff or a lot of pathology, it becomes a lot more difficult. So if you look at it on this diagram, I've shown you this before, and to remind you that when we're using mechanical ventilation, rather than in spontaneous ventilation, we're using a positive pressure, think of a bicycle pump, to drive a volume of gas with this pressure into a lung. And as you do that, clearly you're going to expose your lung to the risk. If you've got a very stiff lung and you apply too high a pressure, you're going to get barotrauma or pressure trauma. And you can see very much akin to a balloon. You use too much pressure, you'll pop your balloon, and this can happen at both the micro and the macro level. At the macro level, you'd call this pneumothorax. At a micro level, you would get lung damage that you see commonly in neonates in the practice that I had, where you get your alveoli breaking down because of barotrauma. That's because of pressure. The other thing that we see is stretch injury, and this is because of volume. If you use too much of a volume, you can see that if it's got into this alveoli and your bottom right-hand side of your screen, you do that repeatedly many times every minute and many minutes in every hour. Ultimately, all of that stretching is going to lead to pathology, stretch marks, and you'll get release of cytokines. And when you get release of cytokines, that not only has an impact locally in your lung tissue, but it also gets into your bloodstream and affects many other parts of your body, leading to an inflammatory response syndrome. Ventilator-induced lung injury, a big, big topic, but just to remind you that using a mechanical ventilator is not without risk. Too high a pressure or too large a volume can cause significant problems. So can you control those? So mechanical ventilators have many, many different modes, and as years pass, they just seem to keep on adding modes of ventilation. But I think if you want to keep it really simple so that we can all understand it, speak in terms of either pressure control or volume control. In volume control, I decide that each breath is going to be fixed in volume, no matter what the pressure required to deliver it is. And I'll show you what this looks like on a diagram in a minute. In pressure control, I dial in a certain pressure, for example, 20 centimeters of water, and regardless of the stiffness of the lung, the ventilator is not going to deliver a pressure of more than 20. So in the first one, I'm not going to deliver a volume of more than, for example, 500. In the second one, I'm not going to deliver a pressure of, for example, more than 20. What does that actually look like? We'll go back to this compliance diagram that I've used before, and I'm now going to put some numbers on it. here I have volume controlled ventilation. You're going to hear these words if you're looking after these patients, and what I'm trying to do is just to help you understand what this actually means when someone says volume control. What it is that this clinician has decided to use a volume of 500 milliliters, and that's what they're going to deliver with each breath. You can see that as the lung gets more stiff, in other words, if you follow the green, the orange, and the red line, the lung gets more stiff, the compliance decreases, the amount of pressure that's required to deliver a volume of 500 goes from 20 to 28 to 40. Again, this is just an example I used. I made this diagram myself, but just to help you understand that pressure is going to be used to deliver a fixed volume. So the pressure is going to be the variable. What's different, if you look at pressure controlled ventilation, which is more like how a bicycle pump works. In this example, I've decided to use a pressure of 25 centimeters of water. And that pressure is going to be fixed no matter how stiff the lung is. What you can see now is that if I take this vertical line, so the pressure remains 25, I'm going to deliver in a very stiff lung a volume of only 250. If the lung is less stiff, that might go up to 500, and even less stiff than that, it'll go up to 1,000. So the volume is the variable and the fixed is the pressure. These are two common modes of ventilation that you'll see in patients in an ICU. And there are lots of other very complex modes that have got all sorts of acronyms attached to them. But what you really need to understand is the relationship between volume and pressure and which one you actually control. As I mentioned to you before, both volume and pressure can lead to what is known as ventilator-induced lung injury or damage to your lung. And in order to try and minimize that damage, there have been a number of studies that have now come out demonstrating that limiting your tidal volume, and we've used 4 to 8 milliliters per kilogram, and limiting your peak and plateau pressure, and I wasn't going to get into plateau pressure because it becomes complex unless you're familiar with all these waveforms. You want to try and keep your peak pressure down, and equally you want to try and limit the tidal volume that you're using with each particular breath. This is just to remind you of the factors that influence inspiratory pressure. We've already spoken about lung compliance, but also if your airway itself is narrow, imagine trying to blow a double thick malted milk through a very thin straw. It becomes very difficult. If you use a fat straw, it becomes very easy. So that's what this is trying to show down here, is that as your airways become narrow, the resistance increases, and that can also lead to an increase in inspiratory pressure. And one of the things you should be monitoring for on your ventilator, when you look at all these different dials that are up there, the things that I'm interested in is I want to keep my peak inspiratory pressure less than, for example, 35 centimeters of water. And again, just to emphasize, these numbers I've used as illustrations, not as absolutes. And in order to maintain those low pressures, I want to make sure that I don't have issues going on in my lungs. I'm not going to go through all of these in detail, but they'll be in the slide deck if you want to see them afterwards. In particular, though, I will focus on ARDS because that is where you're beginning to see increased lung stiffness, loss of compliance, and in fact, looking at some of the pathology, you're getting microhemorrhages, which is also leading to a loss of compliance. The last of my 4 knobs on my mechanical ventilator is frequency or respiratory rate. And again, this is just to remind you that CO2 is inversely proportional to frequency, so that as my frequency increases, my CO2 will decrease, and that's all driven by minute ventilation. So, adjusting the ventilator parameters on my little hypothetical ventilator, which is really what a ventilator is. In order to adjust oxygenation, I focus on pressure gradient of oxygen in the alveolus and the blood, which is FiO2, that's the inspired concentration of oxygen. And I focus on PEEP. Remember the balloons, I want to make sure that I'm keeping my balloons well inflated to optimize surface area. So these are the things that are going to drive oxygenation. Ventilation, in other words, CO2, is going to be driven by my minute ventilation, which is my frequency, and my tidal volume. And my tidal volume is either going to be what I have put in volume controlled ventilation, and I use the example of 500, or the pressure that I've dialed in, and I use the example of 25. Clearly, if you've got a lung that's changing and you dial in a fixed pressure, your volume is going to vary depending on the stiffness of your lung. So these are things that you need to think about when you're actually ventilating these patients. This is a very old slide made by a colleague of mine in the last century, actually, in the 80s and 90s. And basically, when we think about mechanical ventilation, what we're trying to do is to ensure that we ventilate in a safe window. In other words, we don't want to overstretch the lung by using too high a pressure or too high a volume, but we also want to make sure that we maintain surface area by not allowing the balloon to deflate too much. In other words, the lung to de-recruit and have atelectasis. So this is the pressure volume diagram. I showed you one from a rat lung before. This is a one that we've drawn just to demonstrate where we ideally want to ventilate a patient. Oops. So when we're monitoring mechanical ventilation, remember we started off by saying what are the things that we want to do. So clearly you want to minimize lung injury, but the real reason you're putting patients on a ventilator is that they're unable to oxygenate well enough or unable to ventilate well enough. And ventilation, as we've stressed a number of times, is CO2. So the things that we want to monitor, and without invasive monitoring, is you can monitor your oxygenation with your oxygen saturation, and the goals we'll come up with in a minute, but normally you try to keep that above 90, and you want to allow your CO2, because we're using volume or pressure limited ventilation, your CO2 will go higher than normal, but essentially that's the monitor that your ventilator is actually doing what you want it to do. So this is just regular reassessment of mechanical ventilation parameters. My own practice is I cruise around an ICU looking at ventilators all the time. And basically remember that patients are dynamic. They're not static. What you see from 1 hour may change very quickly. And so it's your job as the clinician to ensure that you're continuing to provide your patient safe, supportive care until such time as their body either responds to treatment or improves by itself. So we're going to talk about weaning in a little bit, and I'm going to leave that over to Gemma. I'm not going to get into this slide. It is there in your slide deck and allow you to actually go and have a look at the things that actually matter, but we've actually mentioned all of those things a number of times to date. So I walk around an ICU, I used to a lot, and when I walk around, my eyes are first cast on the patient, not on the screen, and I think that's really important. Sometimes people get so absorbed with looking at the numbers on the screen that they forget that the patient's chest may not be moving, even though at the moment these numbers look okay. And once I've assessed my patient, which doesn't take long to do, I then look at the screen. And the things that I'm going to pick up and focus on for ventilation clearly are going to be my oxygen saturation, which in this particular, and again, this is a screen grab, is 95%, and my end-tidal carbon dioxide, which in this case is 32. These numbers are going to vary depending on your goals, but this is what reflects ventilation. This is cardiac output and blood pressure. And obviously I want those to be in the right parameters or brackets that I'm going to choose for my particular patient. But is my ventilator doing what I'm asking it to do? This is what I'm going to focus on, because this is the end point of what a mechanical ventilator does. So I'm going to pass it back to Gemma now, and she's going to talk about coronavirus in the time of SARS.
Yeah, can everyone hear me?
Yep, you're good.
Excellent, okay. So just bear with us while we transition to presentation mode here again. So can everyone see my slides? Bilal, is that a yes?
Yes, we can.
Excellent. I can't see the chat at the moment. So to hone in specifically on coronavirus and the ways in which it affects the physiology, pathophysiology, and the management tools that we have, we're going to start with a case. This has been anonymized, but this is a conglomerate of the last 3 patients that I worked with over the past week. So Miss G is a 61-year-old lady, and she's come in to the hospital as a ward patient. She's on the inpatient GIM floor, and she's got confusion and fever. And that's how she presented, was with confusion and fever. She was driving erratically on the road, and someone brought her in. She actually denies any respiratory tract symptoms whatsoever. And her past medical history, she tells you that, you know, she's doing pretty well. She's had some vascular comorbidities. She's had an MI in the past, but she's been stable after her stent. And she had a stroke about 10 years ago, but she hasn't had any issues since. At baseline, despite these comorbidities, she's walking up 3 flights of stairs just fine. And as an aside, for anyone who wants sort of a quick and dirty way to assess the ability of someone's heart and lungs, if you ask them, can you climb more than 3 flights of stairs? That gives a pretty good indication of adequately functioning or well-functioning cardiorespiratory organs. So in terms of what she does for work, she works as Air Canada reception at the Pearson Airport. She doesn't have any family here in Canada. She hasn't been traveling herself. She's not a smoker, and she drinks a couple glasses of wine a week. When she's first seen in Emerge, she's got a fever of about 38.1. She's hemodynamically stable. Her rest rate's a little high, but she's within normal parameters. And she's sitting decently on room air. Sitting up, she's at 96%. She looks pretty good overall. She's a little bit confused, but she's doing okay. On her chest x-ray, you see bilateral pneumonia and no ground glass opacities. Her nasal swab is positive for COVID. So you admit her to the floor, and the plan is for supportive management. You're going to give her oxygen via a nasal cannula should she require it. Right now she's doing okay. And you assume that it's going to be a pretty short admission. So just to take a step back, the way that COVID patients have been presenting to either the Emerge or to the COVID assessment clinics, about 50% of them are febrile at the time of admission, but the absence of fever does not exclude COVID. And about 10% present with GI symptoms. They get diarrhea and they're vomiting, and this actually happens before they become dyspneic and develop a fever. The last point here about the silent hypoxemia, I really wanted to focus on. There's a large proportion of patients, especially in the elderly, but also younger, who are presenting with hypoxemia, a low sat, and respiratory failure soon develops, but they don't have any dyspnea or respiratory symptoms on their initial presentation. They deny shortness of breath, they deny chest pain, and they're not coughing. And then it's only after you take their vitals and you look at their imaging that you see that they're actually hypoxemic, and soon after they deteriorate. The physical exam is non-specific. About 2% of patients might have some pharyngitis or tonsillar enlargement, but because of the sort of limited value of physical exam in assessing these patients, especially in the Emerge, many are now questioning whether or not it should be done in terms of actually putting your hands on the patient. In terms of the epidemiology, most cases of COVID are very mild, but about 14% require hospital admission, and that is for supplemental oxygen. And then about 5% go on to require ICU admission. The typical course of this illness is that you are exposed, and then usually about 4 days later, the average range is 2 to 7, but usually about 4 days later you develop some sort of symptoms. And the incubation range is up to 14 days, which is why when you hear on the radio or at the COVID clinics to self-isolate for 14 days, this is where that's coming from. The typical evolution of severe disease is that dyspnea, symptomatic subjective experience of dyspnea, occurs 6 days post-exposure. And initially, these patients might look quite stable, such as our patient, Miss G. So they're admitted to the wards. And then about 2 days after that, if they're going to become severe, they typically develop rapid deterioration, typically on day 10 post-exposure. And it's really remarkable. Just over the past week, I've worked with quite a few of these patients, and when I review their charts on initial presentation and for the first 1 to 2 days, they are very, very stable, and then all of a sudden they deteriorate. So it's something to keep in mind for sure. Another point that I wanted to speak about early on is the need to consider the ceiling or the upper limit of treatment for each patient when they first present, so that you have a plan in place should that sudden, very rapid deterioration occur. And if we look at the existing NICE guideline, it recommends how to triage suspected COVID patients even prior to NP swab confirmation, to see where they should go and whether or not ICU would actually be considered appropriate for these patients should they deteriorate. It's important to note that in other countries, an age-based cutoff has been used. In Canada, it is, I believe most of it is at the provincial level, but the guidelines are not age-based cutoff. It's pertaining to frailty and comorbidity and the 12-month mortality risk. I haven't quoted specific cutoffs and guidelines because they have been changing so frequently over the past couple of weeks, but know that it is based on someone's comorbidities and their overall frailty. So for patients, especially those over the age of 65 who have stable disabilities, who don't have stable disabilities, you're going to be using a validated tool such as the clinical frailty scale. Anyone who is frail, you then ask yourselves, is critical care appropriate for this patient or not? And the reason to be very thorough in this sort of mental exercise, but also your clinical assessment, is that there is this shortage or potential shortage of ventilators. So we want to have a very clear plan established in advance. So anyone with considerable frailty, you need to think about whether ICU management would be appropriate should they deteriorate versus, unfortunately, whether they should be palliated. So in caring for COVID patients, this is just sort of a preemptive slide to let you know that the following guidelines and slides have been taken from the University of Toronto Interdepartmental Critical Care Guideline, and you can find them probably through this link. It's through many links, but this is one of the links that provides that information. And it is updated regularly. So in terms of ward management, so prior to respiratory deterioration, when your patient is still fairly stable, you want to make sure they're on oxygen and you're titrating it to a SAT of about 92 to 96%. I want to emphasize that patients should have a surgical mask placed over their mouth and over if you can, any nasal cannula to try and prevent any aerosolization or respiratory droplet spread when these patients are coughing. Usually we would start at about 5 liters per minute and max for the nasal prongs at 6 liters per minute. As we discussed earlier, you'd then escalate if you're still not meeting your saturation target to a face mask, a non-rebreather, and depending on where you are, high flow nasal ventilation. But again, check where, because some places don't allow for this. If you're using FiO2s of more than 40%, you should be using a Venturi mask. It's a specific type of face mask that just helps provide a more accurate FiO2. And then CPAP and BiPAP are contraindicated in many hospitals. In terms of your hemodynamics, most guidelines are recommending a conservative fluid approach wherever possible. So contrary to your typical sepsis guidelines where lots of fluids, lots of antibiotics right up front, the hemodynamic management of COVID or suspected COVID patients is a conservative fluid approach. For patients who would typically require nebulized bronchodilators, such as your COPD exacerbation, these patients we're avoiding nebulizing, so you can still provide it through an aerospace chamber, but the actual use of nebulized solutions is typically avoided. Antivirals, at least in Toronto, are not being recommended because the evidence is all up in the air and changing. And empiric antimicrobials for bacterial co-infection depend on whether or not the disease course is mild or moderate versus severe. When I refer to empiric antimicrobials, I'm not speaking to the use of azithro and its potential merits in treating the virus itself. I'm speaking to the use of your typical antibiotic regimen to treat co-infection with bacteria. So for mild to moderate cases, we're not recommending antibiotic use, but for severe cases, so for the cases that require either mechanical ventilation or hemodynamic support, all patients are having endotracheal aspirates sent for culture, and in the interim, they're receiving empiric antibiotics, typically ceftriaxone 1 gram Q24, And if there's an allergy, the quoted guideline is recommending moxiflox. Just a word about Toronto's perspective on high flow nasal oxygen, which is above 15 liters. Depending on your local policy, it is or is not considered. These are the sources that have been used to make these recommendations. And just the take-home point here is that staff, if there is a patient on high flow nasal oxygen, staff should be using a tested and confirmed well-fitting N95 mask. When you're using, also one other point, when you're using the high flow nasal oxygen, the patients themselves should still be wearing a surgical mask, and it should cover the nose, the mouth, and the cannula. In terms of CPAP and BiPAP, the take-home point here is that these two tools, aka non-invasive ventilation, can be used for hypoxemic respiratory failure, but there is quite a risk of potential aerosolization involved, so most places are not recommending their use. However, it's important to make a distinction here. It's not recommended for patients who would require ventilatory support solely for the point of COVID, but there are many other patients who require these therapies on a regular basis. For example, your patient who's admitted and has a history of severe OSA, and the guideline suggests suggests assessing whether it's possible to safely avoid using CPAP for these patients. For example, in OSA, if they're not on opiates, they may not need CPAP at night. And then for your other patients, thankfully there aren't too many of them, but those with chronic respiratory failure, secondary to something like ALS, if it's indicated and they need that CPAP support, it's suggested that you contact infection control and have them placed in an appropriate room, typically negative pressure or with other COVID confirmed patients. So just in terms of your general care and the approach to the COVID positive patient, we're talking back to the physical exam here and minimizing your exposure to the patient. So physical exams in the hospital where I work, it's limited to one physician in the room with the patient. They typically stand at the door. They're not going right up to the patient. They're not auscultating on a daily basis. And again, for non-vented patients, we're avoiding auscultation. For vented patients, immediately post-intubation, if you have other tools to confirm correct ET placement, so if you have your end-tidal monitor and you can see symmetrical chest rise, you can see misting around the tube, that's usually sufficient, especially if you're using a glide scope or some other sort of direct visualization tool to watch the cord pass through those two, to watch the tube pass through those cords. In terms of when you do want to auscultate, if there's any change in your respiratory status of that ventilated patient, you would use the dedicated stethoscope per patient room and make sure you're cleaning it both before and after use. So in case of respiratory deterioration, it's very important that we determine which patients are appropriate for the escalation of care and to ensure that the entire team from the MRP down to the junior resident is aware of this. So some of the ceilings include whether or not this is a patient for comfort versus active management. And again, you want to stay away from looking solely at someone's age. You really want to think about their functional baseline and their frailty. You can have limited resuscitation where you're providing nasal oxygen and you're still actively caring for that patient, but you're not going to intubate and ventilate them. And then you should think about whether these patients are appropriate either for consultation or admission, one before the other, and then whether or not invasive ventilation or ECMO would be an option. So one of the questions that was raised earlier is who do we consider for need for early invasive mechanical ventilation. And so these are some of the parameters that have been discussed in the guidelines. Worsening hypoxemia, hypercapnia, or acidosis, typically hypoxemia beyond 6 hours that is unresolving with an FiO2 of 40 to 50%. You should start thinking about calling your outreach or your intensivist. If someone is extremely tachypnic, and they have been for a long time, you want to be thinking about whether they can maintain that respiratory drive or whether they're fatiguing. If there's any instability, and then if they are starting to become obtended. So at the bottom here is just sort of your one-liner. So you think about consulting ICU for anyone with an FiO2 greater than 50% or who requires more than 10 liters of flow via face mask. Okay, PPE. So this is a hot topic right now. Each hospital in Toronto has their own variation of the recommended PPE to use and to not use and when you need to be using it, but they all meet a minimum requirement and a minimum standard that's been established by the Ministry of Health. So you have your essential ones, including CPR, bag mask ventilation, non-invasive, high flow. The two that I wanted to point out were the ones that my team and I had difficulty clarifying for ourselves, practically speaking. It's the care of any intubated patient who has COVID. It's not that you'd need an N95 whenever you're near them. It's specifically when there's a risk of possible circuit disconnection. So if the nurses are turning that patient, if you're in the process of proning that patient, or obviously if there's any suctioning. And then the last point down at the bottom of the slide here, evidence has suggested that you do not need an N95 for higher flows of non-invasive ward-based oxygen supplementation. So for 6 to 10 liters, although that is a higher flow than your average, 2 to 4 liters, that is not a flow rate that supports aerosolization at this point in time, or sorry, that has been shown to cause aerosolization. And so for these patients, an N95 is not required, but always check with your hospital policy. So back to our case of Miss G. Remember when we first met her, she was actually doing okay. And now it's 3 days later and you're covering the outreach team and you've been paged to come and assess because she's extremely restless and agitated. And when you look at her, she's sitting there in the bed, she's clutching at her chest and she's got significant work of breathing. And I have to say, I have seen these patients, they look just like this. And it is a little bit frightening because they deteriorate so quickly. So when you look at her vitals, she's febrile, she's now tachycardic, her blood pressure is holding on, but she's tachypnic and her sats have dropped. She's at 88% on 15 liters. So she's not doing so well and she is deteriorating. So you recall, you get a portable x-ray and this is what you see. This is quite typical for patients with severe COVID. You see these patchy infiltrates, the ground glass opacities, and they're typically peripheral and they're basal. And they are bilateral as well. And with increasing severity of disease, you're going to see an increased number of lung segments involved. And as the disease progresses, these areas of patchy, sort of diffuse ground glass opacities are going to coalesce into denser consolidations. So here's a CT, it's a series of CTs. The top row, A, B, and then E, are from a patient who had a more mild disease course, and the bottom row, C, D, and F, are a more severe. So on the top, you see a 50-year-old guy, he's day 8 and day 15 of admission on the CT there, and the chest x-ray correlates. And then the bottom row is a 60-year-old with severe COVID on day 1, and then again, 3 days later, despite supportive management. So you can just see how you get this sort of peripheral bilateral coalescing consolidation, and then you eventually get this total whiteout on your chest x-ray. So these are real numbers. I've taken them from a couple of patients for confidentiality reason, and I projected them onto this graph, but they are real. The patient's SAT was pretty stable, and then it suddenly tanked on the 2nd of April. And at that time, their FiO2 and flow rate requirements went significantly up. And we were able to recover their SAT somewhat, but it's just a nice way to show that deterioration there. So I'm going to pass the mic over to Dr. Cox Sr. for a discussion of ARDS, which is where this respiratory deterioration eventually leads. So,
Okay.
Here we go.
Should be good, Peter.
Yeah.
Should be unmuted, yep.
Sorry, let me just get out of this. Okay, so this is the last slide that Gemma had up, and essentially somebody
Sorry,
asked.
we don't see the slide. Sorry.
Okay, hang on. Hang on.
Should we pause for some questions first before going on to ARDS?
Do that while I get my screen sorted.
Okay. So just looking at the conversation here.
Why don't you let?
Or yeah, actually, Bilal, why don't you guide the questions?
Sure. So I got a few here. I'm just trying to look because I know some people are answering the questions as well.
Yeah,
So one question I had here from somebody was, any advice on somebody that works at a COVID assessment center? Our site is doing these assessments through OTN. and normally get the nurse to listen to lungs, but is this not needed to, and basically the question is auscultation not needed in this
Yeah.
case? We can minimize the risk of exposure.
So I can only speak to I've worked at 2 of the assessment clinics so far, and the protocol differs depending on where you are. The sites that I've worked at are not recommending any auscultation whatsoever, whether that's in the COVID assessment clinic or actually in the MERGE even. We're not auscultating because we're trying to minimize transmission.
Okay. I guess we'll do one more, and then, I mean, we'll let
Sure.
Top finish up, and then we can do the Q&A after. To clarify, is there a potential risk of aerosolization with high flow nasal oxygen? Is that why we need to wear N95s with these patients?
Sorry, can you repeat that?
Sure. Is there a potential risk of aerosolization with high flow nasal oxygen? Is that why we need to wear N95s with these patients?
Yeah, and so just to clarify, high flow, when you refer to high flow nasal ventilation, that's different from saying higher than normal flows, 6 to 10 liters on a non-rebreather. So for the latter, for that 6 to 10 liters on a non-rebreather, you don't need the N95. When we talk about high flow nasal cannula, which is that funny sort of machine, it looks like an elephant trunk and allows like flows of up to 20 to 60 liters. The studies were done by the WHO and the NHS, and I was just speaking to our ID guy yesterday about this. They took a drum and they oscillated that drum at very high frequencies in order to aerosolize the virus and determine how big it is. And when they were doing that study, it looked as though high flow nasal ventilation most likely does not cause aerosolization, but just in case, the recommendation remains wearing an N95 mask for these patients. Did that answer the question?
Just waiting for the person to respond, but I don't know. Yep, it did. Perfect.
Okay.
Awesome. So we'll move
Awesome.
on to ARDS, and then we'll save the rest of the questions for our Q&A when we're done these
Okay.
slides. Perfect.
Cool.
Thanks.
Okay, so ARDS, adult or acute respiratory distress syndrome, goes back to the late 60s and early 70s when it was first described. But essentially what it is it's a diffuse bilateral inflammatory lung injury, which is the consequence of a number of different factors. And what we're talking about today is viral infection. If you look at ARDS in COVID, somebody asked a question earlier on, how does this differ from other viral pneumonias? Clearly, there's not a lot of pathology out yet, but there's a couple of papers that have come out of China. And what they've commented on is that the findings are very similar to a viral pneumonia. Sorry, I'm just going to pull up something here quickly. These, excepting they seem to be a lot more severe. There's quite a lot of hemorrhagic necrosis, diffuse, fairly early fibrosis, pulmonary hemorrhage, interstitial fibrosis, vascular wall thickening, lumen stenosis, and hemorrhagic changes. And I think what distinguishes this is the incredible infectivity of this particular virus and the rapidity with which those patients that deteriorate do deteriorate. So go back, ARDS, acute respiratory distress syndrome, bilateral inflammatory lung injury with increasing vascular permeability, heterogeneous in both lungs, and it leads to fundamentally all the things we've been speaking about trying to avoid: increasing dead space, a de-recruitment, decreased lung compliance, and a thickened diffusion barrier. There are definitions for ARDS, and these have changed a little bit over time, but really what they have to do with is the amount of oxygen that you have to give a patient to get a certain PaO2, and they don't use saturations here, they use PaO2. And if you look on this particular image I've got in front of you, the P2F ratio in the bottom left-hand corner, for example, is for mild, is they would get a PaO2 between 2 and 300 with an FiO2 of 1. That's how you calculate that in a PEEP of greater than 5. So essentially, if you then go to the severe group, you can see that even with an FiO2 of 1, your PaO2 is only 100. So what these diagnostic criteria are trying to do is to categorize patients into mild, moderate, and severe. And even while we do that, we know that all ARDS is not the same. Depending on what the etiology is, the lung may or may not be recruitable, inflatable, recoverable, responsive to steroids, because I'm sure that'll be a question that'll come up in just a minute. But what we're trying to do is to give people some idea of what the severity of ARDS is. These are the physiological effects that I've already mentioned to you, and I won't go through them in any more detail, other than to say clearly these patients all need mechanical ventilation, and what we do is put them on a mechanical ventilator, and anything we do in an ICU is potentially harmful. So when you put them on a ventilator, what you want to try and do is to minimize the harm that the ventilator is actually going to do to the patient. From a historical perspective, when we first started ventilating patients in the ICU a number of decades ago, we aimed for normal PaO2 and CO2. And clearly in doing that, we recognized in the 80s and 90s that we were damaging the lungs. And so that has led to these strategies of using a reduced tidal volume and reduced pressure to decrease either the pressure trauma, i.e. barotrauma, or the stretch trauma, i.e. volutrauma that you're actually causing to the alveoli. And to do that, you want to decrease the amount of shearing, the inflation and deflation that's happening every time you blow in a breath. And so you actually use a PEEP. And I'm going to give you some examples of how you can use PEEP later on. We mentioned before that clearance of CO2 is inversely proportional to frequency, number of breaths in a minute, and tidal volume. That's the volume of each breath you're delivering to a patient. So clearly, if you're using a strategy where you're limiting tidal volume and limiting peak pressure, remember these are interrelated, your carbon dioxide is going to go up. That's permissive and it's totally allowable. And so now we'd accept a PaCO2 of greater than 55, greater than 60, greater than 70, depending on the patient and also depending on their pH. And we'll get to some discussion of that in a minute. Prone ventilation, I'm going to show you what that looks like. Essentially, that's turning somebody onto their tummy, and that will allow for recruitment, which is ensuring that you're optimizing the surface area of your lung. In other words, by using both PEEP and using the peak inspiratory pressure, you will be able to distend those little alveoli, i.e. the little balloons I showed you before, to optimize the surface area to get better oxygenation. Nitric oxide is something that was developed, or was being developed for many years, but introduced into clinical practice in the 90s. And in certain patients with pulmonary hypertension, they can be responsive, although it has not been shown to be very effective in reports to date of this COVID virus. And also, although it is often tried in ARDS, it isn't a very effective agent in most patients with ARDS. And somebody did ask about extracorporeal life support or ECMO before. I put it in brackets and we can discuss that in a few minutes. This is just to remind you, the strategy of using PEEP is to prevent your lung from deflating to these very inefficient little balloons you can see over here. You want to keep your lung nicely inflated, as I've demonstrated before, using a PEEP that will keep lung volume optimized. And what we do is, this is a little animated diagram I made, which shows that what I'm trying to do is to ventilate my patient where I've got good lung volume on the left-hand side, using pressures that are not too high on the horizontal axis, which will allow me to ventilate the tidal volume nicely with as low a pressure as I can possibly get to give me an adequate volume, which will allow for the gas exchange that I want in this particular patient. Reminder, every time I inflate a lung, I put that lung at risk of either barotrauma or stretch trauma, and that's what we were trying to avoid in ARDS, because previously we in fact probably made many of our patients worse by using ventilation that was much too aggressive. I mentioned the strategy of permissive hypercapnia. which means allow your CO2 to drift upwards. So you're aiming, remember that as CO2 increases, you're going to get a respiratory acidosis. So you aim to keep your pH above 7.25, but clearly that's not always possible depending on how severe the patient's lung disease is. I'm not going to go into this again. It's just to remind you the factors that govern CO2 in all of us. Right, what about prone ventilation? So prone ventilation, I've noticed in reports coming out of a number of countries now that they're turning patients prone very early. Gemma showed a slide earlier on of one of her patients, or a patient with COVID ARDS, and this is an image that I have. A patient with ARDS, it's diffuse, bilateral, involves both lungs, and when you look at a PA or an AP X-ray, it looks like your whole lung is affected. This is a CT scan on the right-hand side of the same patient, and what you can see that all of this haziness, or a lot of it, is actually in the dependent part of the lung. So it's at the back here. And remember that what's at the back, you've got, this is the heart, is pressing on this part of your lung, as well as, in the next diagram, I'm going to show you the abdominal contents. So here you get dependent atelectasis and collapse because of mediastinal pressure on the posterior part of your lung, as well as the abdominal contents pushing on your diaphragm, making your lung volume smaller. And we've already mentioned before that one of our big goals in mechanical ventilation is to try and optimize the matching of ventilation, the tidal volume that you're delivering to the patient, with perfusion. That's the amount of blood that is flowing past the alveolus. And clearly, when your lung is partially collapsed, as it is in this patient in the posterior, you can see this is the patient's bum, back of their head, they're lying supine. And if I turn that patient prone, in other words, face down, as their bum on the top, and I put a pillow underneath their pelvis and a pillow underneath their shoulder girdle, this will allow the mediastinum to fall away from the vertebral column and the abdominal contents to fall away from the diaphragm, which will allow for better lung inflation and therefore better VQ matching. This is what a patient looks like prone, and it's obviously requires a lot of people. There's a bit of a joke about turning somebody prone. It takes 12 people to do it, 10 people to complain about it, and 2 to actually do the process. But on a more serious note, it is challenging to take an adult patient who has got lots of monitoring lines and connections to electronic equipment and flip them over onto their tummy. Ideally, we would do this for 12 to 16 hours a day and make sure that we are keeping the pillows in the right places so patients don't develop pressure sores. This bottom reference here is a proning video that you can see on YouTube if you want to explore any more how to do that. But now, if Gemma, if you're unmuted, you want to comment on these slides as I run through them? Bilal, can you unmute Gemma?
She should be good now. Yep.
Okay, cool.
I'm just going to run from this deck, Gemma, rather than taking it back up.
Okay. Just for the sake of timing. So for those of us who don't have experience in managing ARDS as much as Dr. Cox Sr. does, just a quick simplification. The top left here is a very simple drawing of a patient who's supine. You're looking at the vertebral column, the mediastinal contents, and then the lung fields on either side. And when you add positive pressure, when you ventilate this patient, it distributes evenly because in the normal healthy lung, the tissue is homogeneous. And unfortunately, when you have ARDS, as my dad was just explaining, or as Dr. Cox was just explaining, you've got the dependent areas of the lung filling up with fluid and it settles there. And so the lung itself is now heterogeneous. So when you ventilate that same patient with the positive pressure ventilation, the bottom areas of the lung stay like concrete. They have very poor compliance and they don't open up. So all of that pressure is now concentrated into the top anterior aeratable, I suppose, portion of the lung. And as a result, you get that stretch trauma that we'd spoken about earlier, which leads to the release of inflammatory mediators. And if you recall the physiology of ARDS, it's those inflammatory mediators that then lead to capillary leakage and worsening edema. So you get this bad cycle. If you look at the top right diagram, the tube that you see here represents a capillary, and these are your alveoli. And as your nice, normal, healthy alveoli functions, carbon dioxide is able to go in and oxygen out because you've got a thin diffusion barrier. And what happens in ARDS is you get significant capillary leakage in response to that inflammation. And the fluid then leaks around the alveoli. So not only are you limiting the efficiency of your diffusion membrane, you're also causing an inwards collapsing pressure onto the alveoli itself. So if you look at prone positioning and PEEP, this is again just a simplification. In the supine patient, disregard these numbers, they're just to emphasize the principle. In the supine patient, you've got the mediastinal contents pushing down on a larger proportion of the lung field. And when you flip the patient prone, the mediastinal contents then fall, and they do still compress some of the lung, but it's a much smaller amount. And then when you add the PEEP there, it's able to counteract the compressive force that is created by the edema. And then the next slide, I'm not going to go through all the details here. It's just a checklist for anyone who is involved in the proning of a patient to make sure that you don't miss any of the critical steps or preparation. And then this is from the U of T guideline for ventilating ARDS patients. For those of you who have experience in respirology or intensive care, this will make a lot more sense than for those of us who don't have that experience, but it's just an example of one of the algorithms that's used in the initial ventilatory management of COVID patients. Next slide here, this is a pocket card that I really like. It sort of shows the escalation in terms of ventilatory management of patients from the beginning down to the end, which would be VV ECMO. And we're not speaking about ECMO in this talk because it's just beyond the scope of what we're able to discuss, but it's a nice summary. So in terms of management goals, this is very much hospital dependent. So we're looking at PEEPs, as mentioned, PEEPs starting with 5. Targets need to be met, your physiological targets need to be met using safe levels of FiO2 and or PEEP. Your ventilation target, as mentioned previously, is a pH of 7.25. If your pH deteriorates despite this, and you have a pH of about 7.15 to 7.3, one of the recommendations is to increase your respiratory rate until you get a pH of 7.3 or a PaCO2 of less than 25 on ABG. And the maximum set resp rate is 35. If you have a very severe acidosis with a pH of less than 7.15, you would increase your resp rate to 35. And if it remains very, very severe, you can increase your tidal volume in 1 milliliter per kilo steps until your pH improves. And in that case, you would accept a plateau pressure above 30, potentially. And you would also start to consider giving bicarb. And just as a reminder, pH here is a proxy for your carbon dioxide. So Peter, are you still there? PC?
I am still here, but I'm also aware that they want to get into a question and answer session. So
okay.
I think what's important, I'm just going to stick with your slides.
Sure.
Gemma, you can advance.
Okay. Sure.
I
So
think we've actually covered most of this very well. You might want to just move straight on to weaning and palliation.
Okay. All right.
And if there are any questions, we can actually talk about it later on.
Perfect. Okay, so for weaning means that you are taking the patient off the ventilator and you're extubating them, and there's many steps that are involved. You have to make sure that whatever necessitated that support in the first place has resolved to the point where the body can take over. You want to make sure the patient's hemodynamically stable, that they can maintain their saturation on FiO2s less than 50%, that they have adequate level of consciousness to protect their patent airway. and that they are in fact making spontaneous respiratory efforts themselves. So if you think about it, this is a nice little schematic. You would say, has the first reason resolved? Okay, let's do a trial of waking them up. And you would do this spontaneous waking trial to try and eliminate any barriers for readiness to wean. So you would at least do this daily, or at least reassess the sedation daily. And you do this to try and minimize the chances of weaning failure. So after they're confirmed to be waking up, then you would consider doing your spontaneous breathing trial, where you let the patient trigger their own breaths and you try and encourage them to take over. And this is an important concept to understand, because in the climate of ventilator shortage, we want to wean patients off the vent as soon as possible, or unfortunately consider moving to palliation. Reasons for difficulty in weaning, just a quick list. You could have reasons pertaining to the lungs, the brain, the heart, and the diaphragm, and I'll let you guys review that yourselves later. And I wanted to move on to palliation in the ICU setting. COVID has a 1% mortality rate overall, but for those who are admitted to an intensive care unit, I didn't give a single number because it very much changes depending on which study you look at, but it's definitely above 50%, it's up to 90%. And the ventilator shortage increases the need for palliation in these patients. So general considerations for considering palliation in any patient: you want to think about the code status, make sure that you've tried to communicate with the family. Really important, even in the time of COVID, is to try and confirm people's religious or spiritual rights. And then as you move forward with the palliation itself, you would turn off alarms and monitors and remove any unnecessary clutter from the bed. This is more if the patient's families are able to visit. In my hospital, if there is imminent death, we are allowing one visitor to be present, but other hospitals may not, and depending on the climate, that may change. And then you want to think about keeping drugs that would facilitate patient comfort, but discontinuing everything else. And a really important point with palliative care is that you're titrating the medications to symptom relief, and you are accepting, even if it might feel uncomfortable, you are accepting the various side effects such as sedation that might coincide. So in respiratory failure, when you're looking at managing palliative symptoms, it's the 3 A's. Asphyxiation isn't a symptom, but it's to remind you to think about dyspnea, anxiety, and agitation. So when we're managing dyspnea in the palliative setting, a really important point is that this is a self-reported symptom, and in any situation, if possible, you want to be asking the patient, are you having difficulty breathing? Not everyone with visible signs of increased work of breathing, not all tachypnic patients will actually feel short of breath. So it's really important that we do ask wherever possible. If you're unable to self-report because of sedation or because they're intubated or for whatever reason, the main validated tool to use is this respiratory distress observation scale. It takes less than 5 minutes to complete. And when we're treating the symptoms, you want to ensure that if you do still have monitors on, usually you would take these monitors off, but if you do still have your monitors on, just remember that you're treating the symptom, not the person's saturation. In terms of oxygen, if the patient when awake, and this is more for patients who've now been extubated with the goal of palliation, if these patients had previously derived comfort from supplemental oxygen when awake, you would continue it throughout palliation, even if they then become obtunded, up until sort of the terminal phase of palliative management and death. In terms of non-pharmacological management, ensure these patients are elevated. It is very uncomfortable to have your lungs fill up with fluid, and making sure that the head of the bed is up can help with that symptom significantly. The key, one of the key non-pharm management tactics is a fan blowing dry air. Some hospitals are not allowing this because of risks of transmission. I don't think there's any evidence suggesting that a fan blowing air across a face would necessarily aerosolize, but if the patient coughs, it will certainly spread those droplets. Make sure you're doing good mouth care and making sure these patients can hear you, so make sure that you're providing reassurance whether you're at the door or next to them. In terms of pharmacological management, these are some doses that we use at my hospital. Different hospitals differ, but hydromorph is your main friend for dyspnea. There's very limited evidence for the use of lorazepam as a treatment for dyspnea in palliative care. But if you need it, and if you think it's facilitating treatment of coexisting anxiety, it would be 0.5 sub-Q Q4, and then glycopyrrolate and scopolamine for secretions. Just an important point about these two drugs: glycopyrrolate does not cross the blood-brain barrier, so your patient will remain, it won't add to sedation, versus scopolamine, which does cross the barrier and will contribute towards sedation. So depending on your goal, you would choose one of those. As far as opiates go, just as this is a dosage point, for naive patients, opiate naive patients, you would consider starting with hydromorph at 0.5 to 1 PO or 0.25 to 0.5 sub-Q. And you would do that Q 30 minutes to an hour. You would start this PRN Q 4 to 6 hours, and if they're needing more than 6 PRNs in a 24-hour period, you would initiate a standing opiate order. So you would take their 24-hour total and divide it into Q 4-hour doses, and then take the 10% of that total and add that as your PRN. And if they are already on opiates, you would continue whatever their standing dose is and increase it or consider increasing it by 25% with your PRN breakthrough as needed. For anxiety, we're looking at lorazepam. If it's very, very severe near the end of life, you can use midazolam 1 to 4 Q30. Sometimes you can actually use an infusion. And for agitation, the guideline is recommending methotrimeprazine. I've never used that drug or seen it. The one that I see and I'm familiar with is Haldol. And secretions, just as a reminder, they're usually not uncomfortable for the patient themselves. It's for the family members or the care providers. So here's your palliative kit. These are just quick and dirty if you want to take a screenshot and have it on your cell phone. That's what I do. If you're walking around and you can't remember, these are some appropriate doses. And then pretty morbid slide to end with, but these are the final hours, things that suggest impending death: modeling, cool skin, irregular breathing, and upper airway secretions. All of these things are signs of impending death, but they are not specific to a certain time frame. This last point, the loss of facial tone, the patient will start to make like an O shape with their mouth, and they will lose the nasolabial fold and be unable to open their eyelids. These patients in several studies have been shown to pass away within 2 to 3 days. So those are more sensitive signs of impending death. And that is it. I know we're out of time, but just quickly here to take a look. I've compiled a set of resources. This is what I used to make this talk. So we've got general guidelines here and general overviews, as well as at the bottom, this illustrated primer. This goes into more specific details about specific medications or specific physiological targets. For those who are not ICU trained, I highly recommend you take a look at the first 2 links. This is a Toronto-based resource. It's free and it provides very clear lectures, pocket cards, as well as more lengthy and advanced lectures for adult intensive care. And then the Heart Lung website provides really good overviews and modules that are all free for people who are working in an ICU day to day. The bottom 2 are resident guides. They're older, but they're really helpful just for practical tips. In Ontario, these are some resources that we've been depending on. ICU Pandemic is the University of Toronto Interdepartmental Critical Care resource, as well as Quick ICU training. And this top one is UToronto's sort of news feed with various resources as they come up. These are general guidelines again, and then I didn't go into the eMERGE resources much because that's not the focus of this talk. Airway specific is here. I highly suggest watching the simulation videos. It's really helpful to see how many people are involved and where they're placing them to minimize risk of exposure to healthcare providers. Yeah, PPE, again, watch the videos. And then palliation, highly, highly, highly recommend the goals of care module. Having this discussion is super uncomfortable for most doctors or healthcare providers. And working through this module has really helped me in my conversations with patients lately. And so I highly recommend. And that's it. Oh, and by the way, the hood here is made out of a garbage bag. And that is everything.
Awesome. Thank you so much, Gemma, Dr. Cox and Dr. Cox Sr.
Just Gemma.
I'm going to unmute both of you, and then I'm just going to get into some of the specific questions we had regarding ICU. For some reason, I can't seem to unmute Peter. Come on. There we go. Now he's unmuted. Okay. Let's see. Give me 1 second. Okay, so we're just gonna
Bilal, can you see that slide that you asked me to put up?
Yes, I can. Thank you very much.
No problem.
So we'll start with the ICU questions, and then we're also supposed to have an internal medicine Q&A as well, because we didn't get time to when we did 2 weeks ago the internal medicine session. So we're just kind of I believe there'll be a fair amount of overlap as well. So this first question, please go over the physiology of proning and how it helps. Actually, I think you already did that, so we can skip that one. There was a clarification question about please go over which of the oxygen delivery systems should not be used for COVID. So either Gemma or Peter, if you could talk to that, please.
I can speak to that. Before you answer that, you have to realize it's not a hard and fast rule. It very much varies depending on the hospital, depending on the provincial recommendation. So I can only speak to the hospitals that I've worked at. Most hospitals are looking at avoiding either high flow nasal cannula, so flows above 10 liters, CPAP and BiPAP. Those are the three sort of non-invasive ventilation methods that are supposed to be avoided. And then in a code situation, we didn't get into protected code blues, but in a code situation, they're also trying to avoid bag mask ventilation unless you've got failed management of the airway and unretractable hypoxemia.
Perfect. So I think this comes from the slide where you were talking about intubation. So this question was, what are the general hemodynamically stable induction agents? Just as a refresher. Oh, you got muted somehow.
Can you hear me?
I can hear you, yes.
I think that rather than, clearly drugs like propofol and a muscle relaxant, rocuronium or cisatracurium are the drugs that are recommended, but I think it's important that whoever's going to do these intubations turn to those who've had some experience before, because any of these drugs can be lethal if used inappropriately in either a dose, speed of injection, or particular patient. So I'm reluctant to give you an actual online guided dose.
Okay.
The names of the agents, just for general knowledge, ketamine and dexmedetomidine are considered more hemodynamically stable, but I think as my co-lecturer here pointed out, it's very much dependent on the clinical situation, because even those drugs can have hemodynamic effects if used improperly.
Okay. So there was a fair amount of discussion in the chat about auscultation of COVID positive patients for suspected COVID patients. So a lot of people are asking about clarifying the auscultation. One person says, I work in an ER and are the lecturers saying not to listen to any patient's chest that presents to be seen? Can you also clarify what percentage of patients survive after being intubated or on a ventilator? Yeah, that was a question, sorry. That was two parts.
So in terms of the auscultation, the question is clarify who should be auscultated and who not?
Correct.
Yeah. So again, it very much depends on the accepted procedure at your hospital. If you're not aware of whatever these protocols are, email your infectious control specialist or chair, whoever it is, because they do almost all hospitals are going to have established guidelines as to who should be doing what and when. At University of Toronto, the recommended guideline is try to avoid auscultation wherever possible. The only case scenario where they strongly recommended auscultating a patient was with a change in respiratory status and acute deterioration. That was the one situation that they strongly recommended auscultation be continued. In every other situation, they said, if you are able to rely on other physical exam, such as observation, vital signs, they recommend doing that. But again, what I'm saying, I've summarized sort of a guideline, a general guideline put out by the University of Toronto. You really need to check with whatever's appropriate in your department or your hospital.
Yeah, perfect. So this is for Dr. Cox Sr. Could you briefly go over the physiology of end-tidal CO2 and how it's used to confirm ET placement?
Sure. Without going back to a slide, just if you conceptually think of your lung as being made of a number of little balloons, and those balloons are connected to the outside atmosphere through a straw. So at the end of an inspiratory breath, in other words, at the end of breathing in, my straw has got fresh gas from the atmosphere in it. My alveoli are having oxygen taken out of them as it diffuses into the blood, and CO2 added into them as the blood bypasses the alveolus and the CO2 moves down a gradient from the blood into the alveolus itself. So at the beginning of expiration, the first gas that is going to be measured by an end-tidal CO2 monitor is going to be the gas that's in my trachea. Clearly, that first sample is going to have no CO2 in it because that gas is not exchanging carbon dioxide with my bloodstream. I'll then get a period of mixing where there's gas from some airways that are small but not taking part in CO2 exchange, and gas from alveoli, which is taking part in CO2 exchange. So that's a mixture of gas. And if you look at a tracing on a screen, you will see that slowly the CO2 is actually increasing. And I'm going to try and find a picture of a screen. Can you see that picture?
Yes.
Oh, okay. So here's an end-tidal CO2. So during inspiration, there's no CO2 because this is fresh gas. Can you see my cursor?
Yes,
As I begin expiration, CO2 goes from 0. And then as gas mixes from airways, which don't take part in CO2 exchange, and finally, the only gas that's being exhaled from my trachea comes from all my alveoli. So the end of my tidal exhalation is this point over here. So that is a reflection of CO2 in all of the alveoli. And in this particular case, it's 32. So the end tidal CO2 is this point. This is a plateau, and depending on lung disease, the slope of this curve can be, in a normal lung, fairly steep, as it is here, or it can be pretty shallow if you've got a lot of dead space in your lung, and then you get to that point. But end tidal is a reflection of the CO2 in all the alveoli that are taking part in gas exchange, and it is a reflection of the CO2 that is dissolved in your blood. Does that answer the question?
I don't know if the person who asked the question is still on, so.
Okay, that's fine.
I think that's
But did that answer the question for anyone who didn't have it as a question? Okay.
Yes.
I will move on to the next one here. This question is, why is BiPAP and CPAP avoided in certain situations?
So I think we spoke about that previously, but just to review, in Italy, when they are using these things, they have that big plastic bubble or helmet over the patient's head. Here, we don't have that. So with BiPAP and CPAP, the concern is that if there is some sort of ill-fitting mask, or if there is a breach in the seal in any way, and the patient were to cough or anything like that, you've got extra flow and extra air being pushed everywhere. And so if there's any break in the seal, the droplets, the concern is that they could become aerosolized.
And sorry, one other thing I would add to that is BiPAP therapy for hypoxemic respiratory failure isn't really indicated for most of the time. It's indicated for COPD exacerbation with hypercapnia and a pH less than 7.25 and heart failure exacerbations. Aside from that, you shouldn't really be using BiPAP therapy. Sometimes ICU will use it to maybe temporize, but in these COVID patients, it's just going to delay intubation. So really, if the patient requires that level of care, they should probably be intubated.
So just to clarify, that was Dr. Hamza Qureshi, who's joining us for, he's PGY for internal medicine at U of T. He's
Hello, everyone.
As well. And then also we have Dr. Nazia Sharfuddin. She's PGY for IM at University of Alberta. So they're going to join. Okay, so I'm just going to move on to the next question. There was a family medicine resident who's been doing a lot of phone triage for query COVID patients. Other than dyspnea, chest pain, are there any other symptoms that might prompt you to send patients to the ER, given that not everybody experiences these symptoms prior to decompensation?
Right. So I think that's a great question. And what we need to realize for that is that the only patients who should be going to the emerge are those you can't predict necessarily who's going to deteriorate. You know, using common sense, I would imagine that if you have an elderly, frail patient with multiple comorbidities and a low baseline function, my threshold for sending that patient to the emergency department would be much, much lower. But aside from that, the only reason that patients should be going to the emerge is because they can't cope at home. The line that we're using at the COVID assessment clinic where I work is if you are too sick to stand up, eat, drink, and you can't breathe, like you cannot breathe, those are reasons to go to the emergency department. And the reason not to go before that is because the only thing they can do is help you breathe better if you can't do it yourself. And other than that, you risk exposing yourself further. So for any other random symptom, whether it's, oh, I had a tickle or in my throat, or I had mild diarrhea, the only advice that I've been giving is, and this is based on the powers that be above me, is to self-isolate for 14 days.
Okay, thank you. Makes sense. What else? So if the initial swab is negative, but there's a high clinical suspicion for COVID-19, should we assume the patient is positive, especially for infection control purposes? And if yes, should we retest and assume negative if the second swab is negative?
Sorry, go ahead.
I was just gonna speak about the number of false positives, or sorry, false negatives. So when you look at the correct way to take a nasal swab, it's 15 seconds and multiple turns inside a patient's nose at the posterior nasopharynx. Many people aren't doing these swabs correctly, so there's a quoted false negative rate of about 25%. At my hospital, if a patient comes back negative, but there's a high index of suspicion, they're continued to treat as COVID positive until the repeat swab comes back.
Yeah, I would agree with that. And I've actually personally seen a lot of high false negatives just in our ICU population. And we're sending, if possible, ETT aspirates from suctioning in that case, which is a higher sensitivity than a nasopharyngeal swab. So yes, I agree with that. If it's a high degree of suspicion, then just continue to assume COVID.
Awesome, thank you. So next question. With regards to minimizing exposure to healthcare providers, how often should we check vitals on COVID patients admitted to the ward, not ICU, especially considering we may see a dip in their SpO2 before they develop symptoms of dyspnea, and it would be best to catch this as early as possible?
That's a good question. I think in terms of, and by the way, Nazia, like feel free to jump in, but I think you're still, there's still nursing for those patients, right? So there's still, it's all about your clinical assessment. If you're looking at the patient and you see that they're becoming more tachypnic, get a set of vitals. But I don't think there's a hard and fast numeric limit or target for how often you should be monitoring the vitals. I think it's very much guided by the clinical picture.
Yeah, one thing I'll add to that is there are a lot of patients who are being admitted to hospital on maybe 2 to 3 liters of oxygen, and then within 12 hours are being intubated. My general rule is when I admit someone who's fairly sick to a medical ward, I put them on Q4 vitals for the first 24 to 48 hours, and if they're okay, then I usually downgrade. So if they're on anything above, I think 2 to 3 liters of oxygen, I think they need at least an SpO2 check every 4 hours on the ward, which is the max they can do. And if they stay stable on that for a day or so, then it could probably be downgraded.
Agreed.
Perfect. So next question. Is there any role for proning non-vented patients who are desatting on the ward? Could it help prevent worsening hypoxia and avoid an ICU admission?
Hamza, you want to speak to that one?
Yeah. So me and a couple of my friends actually thought of this, and we were like, why don't we just start, proning all our ward patients? And then we started looking it up, and there's actually some people who are attempting or at least thinking about doing this. There's no data behind this. It makes physiologic sense to try, in my opinion. It also makes sense because the ward patients are a bit more stable. They don't have lines. They don't have tubes. So it doesn't do much harm in having the patient lie on their stomach and then see what happens, but there's no data to prove that this is actually going to prevent an intubation. And then, I mean, if they're getting clinically worse, they're probably going to be intubated anyway. So I wouldn't use that as a rescue maneuver prior to any other thing. But from a physiologic standpoint, actually, I think it's very interesting to see if they would improve their oxygenation if you prone an awake patient.
Hamza, I think you have a case series.
Well, I think you muted.
Bilal, you're muted.
Yeah, sir. So I have a few more questions here. So somebody was saying, can you clarify for all the patients requiring intubation, what is the survival rate approximately? Are there general rules on who to speak with regarding admitted patients regarding goals of care who would benefit more versus who wouldn't benefit for intubation?
So there's a paper, can you hear me?
Yep.
A paper in the New England Journal of Medicine just a couple of days ago. So survival is about 50%. Clearly that survival is going to depend on where you are, who gets onto a ventilator in the first place, and what kind of triaging system you have. I have friends who work in Lombardy in Italy, and they've had to make the awful decisions of who not to put in a ventilator, and your survival rate's going to vary depending on what goes in and what comes out. I think the general rule of thumb is that this has got a very poor survival of about 50%. Those are the numbers that are available at the moment. The other part of that question was?
The other part was, are there general rules on who to speak to about your, I guess the question is more so regarding goals of care and who would benefit more from intubation versus who wouldn't benefit from intubation?
Again,
I can speak to that.
I'll refer you to a couple of publications recently. In fact, one of them's come out of the University of Toronto. There's also a document that's come out of places in Europe looking at how you triage patients and how you put them on a ventilator. It's a very challenging question to answer, and people that are involved in it should ideally have a third party making a decision so that the direct caregiver is not put into this dilemma. The guidance from the U of T, which I've have some familiarity with, really part of it's related to age and comorbidities. And in a paper that was published maybe 10 years ago, the patient's actual worth to society wasn't taken into account. But in the documents that are coming out now, I see that they're looking at healthcare providers as people that should be considered to be given invasive mechanical ventilation.
The provincial public health authority has also provided guidelines on how to strategize, and it's based on your 12-month mortality.
Those are very difficult things to discuss in the acute heat of the moment.
Yeah.
That's why they're leading them to try. That's why they're trying to simplify them.
Awesome. So I have one more here. Actually, I have two more questions here. So this is a bit more of a resource question, but is there any risk of hospitals running out of supplemental oxygen? I haven't heard about anything about this in the news. Not sure how it's actually produced. I think this just kind of speaks to all the resources being used up right now around the world, really.
I similarly have not heard anything on the news. And I would imagine that if it was a severe risk, we would be hearing about it. I can't answer that question because I don't know the answer, but I'll certainly look it up and I will let Bilal have it.
Awesome. Sorry, I'm just going through the chat because it's moving quickly here. Just trying to see if there's anything else here. Is muted. Sorry, I'm just reading through here. Are there any other questions that anybody has? That's the extent of the questions I had listed from the ICU talk. If there's any other questions, we have some time. So I know there's some questions being raised in the chat, but if you want, I can put them out to the speakers. Can we share the GOC website one more time, the free course?
Sure.
Well, I've just got an answer to your question, published 2 days ago. A major NHS hospital almost ran out of oxygen for its COVID patients because there were so many demanding it. So what it really is dependent, it only answers part of the question, is how do we make sure that the suppliers have sufficient oxygen?
Mm-hmm.
And it doesn't answer, there is a risk of hospitals' oxygen supply failing altogether, which could cut off the supply to those needing it. Liquid oxygen storage tanks, no.
We have Danielle in the chat who's saying they have a friend in the UK who had this happen in her hospital.
This is from the UK. That's where I'm reading from.
Yeah.
Yeah.
So Naman, this is the goals of care module here. If you want to copy it down.
And the pallium course, that one's also really good. And the basic pallium course is free.
Perfect.
Unfortunately, you're not really practicing true palliative care for COVID because so much about palliative care is getting to know the patient and their values and what they actually want in regards to their own care. And unfortunately, when it comes to COVID, we don't always have that ability to offer.
So there's a question in the chat about antibiotics and if you would empirically cover anybody for antibiotics for a possible COVID positive case. I think you guys have answered it.
Yeah, I mean, I just want to clarify that because there was a lot of answers in the group chat, just so we're on the same page. I think when you don't know if someone's COVID positive, it's okay to cover empirically with antibiotics and someone who's hypoxic and has a chest x-ray evidence of an opacity. I would then cover them with ceftriaxone if they're just going to the ward. The need for azithro is usually to cover for atypicals, particularly Legionella. However, there's evidence that, these atypicals aren't a major player in community-acquired pneumonia, and there's only really derived benefit if patients are sick enough to require ICU level admission or step-up admission. So I usually, and most of the guidelines, at least in Toronto, are just to stick with ceftriaxone monotherapy for ward patients. Now, if your COVID swab comes back positive, the practice right now is to DC all antibiotics because it's likely the COVID that's giving you the chest x-ray changes. Obviously, this doesn't apply to necessarily the ICU level patient who's being mechanically ventilated. Usually, they will continue antibiotics in those patients, especially if they go into ARDS. But again, that's for a time-limited duration for a superimposed bacterial infection, which right now we don't have great evidence that these patients have.
Yeah, that was what the slides that I had up were pointing to. They weren't specifying whether or not to use antibiotics for undifferentiated hypoxia or patients with respiratory illness. It was really saying when to use antibiotics for empiric co-infection, which is what Hamza was just saying. So just to make that clear, because I'm sorry if it wasn't.
And sorry, there's a follow-up that says if there's no opacity but bilateral interstitial findings, again, if the patient's febrile, hypoxic, I would still cover them empirically until the swabs come back. And then the swabs usually take 24 hours. And if they're positive, then you can DC them.
Yeah.
And someone raised a good point there, been empirically covering with Tamiflu. I would also empirically cover with Tamiflu as well until the swabs come back.
But to be clear, Tamiflu doesn't have a role in this particular coronavirus, correct?
Yeah, no, it does
Correct.
not. Correct. Sorry. It's just to cover for empiric influenza if the patient has that.
Perfect. Just waiting for any other questions that arise in the chat. I think things are slowing down, so maybe we'll go till 5 and then we'll call it a day if that's okay with all the speakers.
Yeah, that's fine with me. Is Nazia there? I haven't heard her.
Yeah.
Yeah.
Oh, okay.
Is it unusual for Nazia to be silent?
No, I was just asking because she hadn't said anything. I hope we weren't excluding her. That's all.
Yeah, no, I was just pulling her leg.
You guys did a good job, so I didn't want to repeat what's already been said.
Clarification: Tamiflu is given empirically for influenza, not for COVID. Correct.
Yes.
The slide deck will be available probably in the next week or so. Once I get it from the speakers, I just gotta put it into a PDF format, and I will send it out alongside the video once we have it uploaded to YouTube. A lot of thanks.
Bilal, I've actually heard from a number of people in different parts of the world that couldn't get on, and I don't think it's because you exceeded the numbers. So you might want to just check your processes.
Yep, I will look into that.
Yeah, no, it's just it's just so that you know about it. Yeah.
Yeah, thank you. How long would you? Oh, this question was asked. Nazia is saying, how long would you expect the lung to be? The what? How long would you expect the lung to be cleared?
Someone sent this question to me directly, so I thought I would just put it on the chat so everyone can see. What I'm understanding from the question is, how long does COVID positive patients take to clear? Correct me if I'm wrong, Dr. Cox, Senior, but the information from Lombardy, Italy was showing 2 weeks, 2 or 3 weeks on the ventilator, and about 2 weeks for non-ventilated patients. But I think the evidence is still emerging.
Yes, I'd be hesitant to put that, and the New England Journal says 4 to 7 days. So I think it's going to change as things.
A lot of variation.
Because the other thing that's actually changing is the age of patients.
Mm-hmm.
Earlier on they were predominantly older people, but it seems like there are a lot of younger people being affected now as well.
We got a good question here in the chat. I had it. I don't know where it disappeared to. Give me one second. Can somebody clarify, if in the community we have somebody present with low SATs and are waiting for EMS, if we put on a 100% non-rebreather mask, do we need the N95 mask on?
Sorry, hang on. Say that again. So if there's a patient in a community awaiting EMS,
correct,
and they
non-rebreather mask on them, do you need to have a N95 mask on as a provider?
No. As per U of T guideline, no, you do not.
I believe they put them on a TAVISH mask though, right?
Yes, that's correct. So the patient never needs the N95 mask. Just to be clear,
do we need to put the N95 mask, like as providers?
Yeah. So you'd put the patient on the TAVISH mask, and you'd give the provider. So the guideline that I have says no, you do not. The only things that require N95s are high flow, CPAP, BiPAP, bag mask, intubation, CPR. So the guideline that I have says no, but I've also seen some people just feel very uncomfortable with that, because you can still crank your oxygen up to like 10 liters on a non-rebreather. And those, I have seen people wear N95s, but it was because of their own comfort, not because of a guideline.
Okay.
Yeah, the AHS guidelines are also similar for those on the West Coast.
So AHS is Alberta Health Services, just to clarify. Acronym. Okay, so another question here. When does decompensation generally happen after symptom onset, i.e. when is the highest risk period that we should keep alert / monitor for high-risk patients? So for example, we get an elderly patient admitted for mild hypoxemia, mild work of breathing, fever at day 5 of symptoms. Should we keep them admitted until day 10 of illness, or even if they slowly improved or stabilized within 1 to 2 days?
So my understanding is, and again, I can only talk about where I've worked, but I've seen them stay admitted because it's typically day 8 or day 10 post-exposure. And but for the patients that I've worked with, it's usually day 1 to 3 after admission, because by the time you're admitting, they've already presumably had symptoms for a day or 2, and then the incubation period was presumably anywhere from 2 to 7 days prior to that. Hamza, have you seen anything?
I mean, I've seen, so the decompensations I've seen have been all following that classic, day 10, day 9, they get intubated, and day 7, they get admitted to hospital. So, I mean, that's just based off of the anecdotal reports coming out of Italy and China. I would be very hesitant to send someone home on day 7 or 8 when they're, not feeling well and still short of breath and have opacities on their x-ray. I mean, it's a clinical judgment call. I don't know if I would wait till day 10 necessarily if they're getting better. It really depends on how reliable the patient is as well. So it's kind of a judgment call.
Yeah.
So
Okay, that's the slide I was looking for.
Tavish, somebody's just requesting what a Tavish mask is. Like in the family medicine setting, we have a non-rebreather. They're just asking what a Tavish.
It's a specific type of mask.
Okay.
So I'm not sure whether it's widely available in the family medicine type setting. I'm trying to find a picture on my phone to show you guys, but it's a specific type.
Mask that you've got on in the image of anesthesia?
It looks like that.
Okay.
So it's got little venting ports.
Okay. The follow-up was that just took a look online. It's not available. We have the old-fashioned one. Okay. I guess Kapil has a follow-up question too. I've heard COVID's very quick, so should we keep them until they're past day 10? My understanding was that if they're stable, you don't need to. But maybe Hamza or Gemma or somebody can speak to.
I think you summarized that well, Bilal.
Awesome.
Okay.
Okay. Do we have any other questions? It's 5 p.m. So I know we were scheduled to go for another 15 to 20 minutes, but if there's not any other questions, maybe we will call it a day. If anybody else has anything to add, feel free.
I think the big thing with COVID is that it's going to be a shared decision making with ID and IPC. So COVID suspected patients, at least in Alberta, we're really trying to get guidance from them because the medications are changing so quickly that what we read about yesterday could be outdated. So just keeping that in mind.
Yeah. Okay, so with that being said then, thank you so much for Dr. Gemma Cox and Dr. Peter Cox for joining us today and for giving such a great talk. I know, Peter, this was your first time using Zoom. I think you did a fantastic job. And hopefully we can have you guys join us again in the future. And thank you for everybody for tuning in. Definitely do give our website a look. Take a look at the YouTube channel if you haven't seen the previous talks. And we will keep you updated for any future talks.
In my pleasure.
Thanks, Bilal, for moderating so well.
Thank you.
Okay.
Take care, everyone.
Thank you.